You developed your body to legendary Instagram bodybuilding proportions, getting praises and inappropriate emojis left and right. You look like a Roman statue. People are falling off their bicycles and crashing a car when they see you walk down the street. But what's the point if you can't pay it forward? This is the most important video you'll ever watch if you want to ensure your legacy after years and decades of blasting gear. Welcome to the How to Get Your Partner Pregnant deep dive video, where steroidal contraceptives are not allowed. Vigorous Steve here. Alright, so you're ready to take the next step in life and put a little mini-me bodybuilder on this planet and nurture and coach and guide that little rascal all the way to the Mr. Olympia stage, but you've been blasting your socks off for your own selfish aspirations to make it to the Mr. Olympia stage? Don't worry, buddy. Daddy Steve has got you covered. But first, let me drill it into your thick skull that this process is going to take months, if not years. It'll take considerable time for your semen parameters to become acceptable, and then further down the line become super duper fertile, ready for conception, especially if you've been taking steroids for a while. So don't get discouraged along the way. You can expect to get smaller, you can expect to get weaker, you can expect to gain a little bit of body fat, perhaps turning yourself into a full-blown dad bod in anticipation of becoming a father yourself. And oh yeah, by the way, the dad bod will come well before actual parenthood does. So be ready. Now take it from me, as soon as you get the good news and you know that your partner is pregnant with a healthy baby, once you start to gain train, the transformation is going to be a lot of fun and you'll get that killer combo physique back in no time, well before your child is born. In order to get the highest possible fertility parameters, you need to come off all non-bioidentical performance-enhancing drugs, ancillaries, and medications as well. And then further down the line, you might need to come off exogenous testosterone TRT therapy as well. The negative effects that anabolic androgenic steroids and selective androgen receptor modulators have on male fertility is honestly poorly investigated and documented. There's a lot of conflicting scientific evidence, but the general consensus is that anabolic agents impair fertility in both men and women, often resulting in complete infertility, even at medically accepted therapeutic dosages. I reviewed all of the scientific evidence regarding anabolic androgenic steroids and their effect on fertility when they're available in this video. I would highly suggest you to give this a watch. And yes, I'm well aware that both Proviron and Halotestin treatments might aid in male fertility. This was actually proven scientifically in studies stemming from the 1960s and 70s using subfertile men who were not completely azoospermic. So if you're a golden age nut hugger and you want to forego the latest scientific evidence, be my guest, but your mileage might vary. But I'm also well aware of the old wives' tales, good old gym bro lore. By increasing your weekly testosterone dose to, let's say, 500 milligrams, 1,000 milligrams, 2,000 milligrams exogenous testosterone weekly even, might help with spermatogenesis as well, allowing you to keep blasting gear, keep all of your gains, and still get your partner pregnant nonetheless. The idea here is that a high enough concentration of exogenous testosterone might permeate into the testicles, initiate spermatogenesis in the seminiferous tubules of the testes in a similar extent that intratesticular testosterone would, stemming from the Leydig cells, which is probably completely shut down because your luteinizing hormone and follicle-stimulating hormone levels are completely bottomed out. Whether this intratesticular testosterone is stemming from the Leydig cells being initiated by luteinizing hormone or human chorionic gonadotropin, or stemming from exogenous sources being in such high concentration in the rest of your body that it literally enters the testicles and starts spermatogenesis, doesn't seem to matter, even in the absence of follicle-stimulating hormone. And let's be completely honest here, the amount of anecdotal evidence is astounding. How many people do we know in the fitness community that got their partner pregnant while blasting their socks off, running grams upon grams of gear, even using Trenbolone? I got my partner pregnant on Trenbolone. I got my partner pregnant on Testosterone, which was actually designed as a male contraceptive, right? The stories are aplenty. Unfortunately, there's no scientific evidence to support this quote-unquote hypothesis, even though if you understand basic human biology, it could definitely be true that exogenous testosterone might result in pregnancy. Again, there is some scientific evidence that exogenous testosterone, Proviron, or Halotestin actually improve fertility parameters in men suffering from subfertility. Unfortunately, all of the studies performed on humans going up to dosages of, let's say, 600 milligrams weekly did not investigate the effects on spermatogenesis or overall semen parameters. However, being the evidence-based research nerd that I am, I was able to find an animal model that proves that, quote-unquote, high-dose testosterone from exogenous sources might improve testicular function and fertility parameters, but not in the way you think. This study, performed by Ann et al., published on June 1st, 2020, so it's reasonably recent, titled The Impact of Exogenous Testosterone Supplementation on Spermatogenesis in a Rat Model of Oligoastenospermia. In this study, the researchers used 8-week-old male sprog dolly rats and treated them with 4 weeks of gluconosides of triptorigim pill 40, abbreviated to GTW, impronounceable compound, to induce low sperm count and poor sperm motility. So that's a similar effect you would expect from exogenous anabolic androgenic steroids, albeit that takes usually a little bit longer than 4 weeks in humans. Afterwards, these rats received either a low-dose testosterone undecanoate at 7.5 milligrams per 1 kilogram of body weight, or a high-dose testosterone undecanoate at 15 milligrams per 1 kilogram of body weight, twice at the start of the study and again at the 4-week mark. So first 4 weeks is inducing infertility parameters, basically, and then a shot of testosterone undecanoate at the first week of the examination and at the 4th week mark. Then at the 8th week, they started examining semen parameters. Now again, converting these dosages to the human equivalent dose using DoseCal, link down below, going for the weekly dose instead of the every 4-week dose, that means that a 100 kilogram bodybuilder would either end up with a low dose of 30.4 milligrams testosterone undecanoate weekly, or at the high end of the range at 60.8 milligrams weekly. That's basically a hypothalamic pituitary testicular axis destroying castration dose, not a large and in charge bodybuilding dose. But let's proceed anyway. In table 1, you see that after 8 weeks, the semen parameters of the high-dose testosterone undecanoate group is very comparable to the control group, which didn't receive any of these treatments, albeit that progressive motility is almost 16% lower at 34.5% compared to the 41% of the control group. Keep in mind that spermatogenesis of sprog dolly rats takes about 50 days, aka 7 weeks. The semen samples are literally the first ones you'll be able to test after the glucosides of triptorigim will 4D GTW treatment. Here in figure 4, you see that while luteinizing hormone and follicle-stimulating hormone levels in the testosterone undecanoate groups is significantly lower compared to the model group, which just received the GTW treatment but didn't receive any testosterone undecanoate. Afterwards, in the testosterone undecanoate group, serum luteinizing hormone and follicle-stimulating hormone levels are still significantly higher compared to the control group readings. So is the increase in intertesticular testosterone and restored spermatogenesis coming from the exogenous testosterone undecanoate, or the 200% increase in luteinizing hormone and follicle-stimulating hormone following the GTW treatment? I would say it's a little bit of both. So why don't we extrapolate highly dubiously from this animal model that if you impaired your semen parameters with some sort of anabolic androgenic steroid or selective androgen receptor modulator, you stay on TRT at a low and effective dose and introduce something to initiate spermatogenesis in the form of luteinizing hormone, follicle-stimulating hormone, or perhaps human chorionic gonadotropin. And to come back to this bro lore, the old wives' tale that exogenous testosterone can initiate spermatogenesis, that's kind of proven in this study, because both luteinizing hormone and follicle-stimulating hormone levels were significantly higher in the CTW-only group compared to the testosterone undecanoate group. You still see a steep reduction in intratesticular testosterone and fertility parameters at the 8-week mark after the GTW was discontinued without additional testosterone supplementation, whereas with additional testosterone undecanoate supplementation, intratesticular testosterone and semen parameters are almost close to baseline again at the high dose group. So a combination of both seems to be desirable. Oh, and before I forget, we'll go a lot more in depth into oxidative stress a little bit later in this video. But in this study, they show that oxidative stress markers were also lower in the testosterone undecanoate groups compared to the GTW only groups, but still higher than baseline readings. And this is very important to understand. Again, we'll go a lot more in depth later on because oxidative stress contributes to the sex determination of your child. Now, there's a lot more to the study, and I would highly suggest you to read it. If you decide to go this route, be my guest. Just do me a solid and read all of the other citations down below. It's a fully evidence-based scientific deep dive to make sure that you get the best information possible when you're trying to conceive. If you stop the video right here, just be forewarned. If you decide to go with exogenous testosterone at superphysiological dosages in an attempt to get your partner pregnant, it's very likely that you'll have a daughter and could potentially have a child with autism or both due to the oxidative stress occurring within the testicles, affecting your semen parameters. So keep watching. If you'd like to know more, leave a like and a couple comments to fuel the algorithm. Much appreciated. Everything is explained in this post-steroid abuse male fertility deep dive. Gentlemen, first, let's get a baseline reading of your current fertility parameters to see how terrible or how decent your spermatoza are, because not all men are azoospermic on a steroid, a cycle like I alluded to earlier, albeit that progressive motility and morphology is usually still in the gutter. Make sure you do a semen analysis while checking for the following fertility parameters according to the updated guidelines from the 6th edition of the World Health Organization Manual for Human Semen Analysis, published in 2021. The ideal abstinence time should be over 2 days, resulting in sufficient semen volume. You can expect about 1 milliliter of semen for every single day that you abstain on average. But the longer you abstain, the more your sperm is susceptible to oxidative stress. Again, more on this later. Semen volume should be over 1.4 milliliters. Sperm concentration should be over 15 million sperm per 1 milliliter. Total sperm per ejaculate should be over 39 million per ejaculate. So that basically means on average 2 milliliters of semen containing each 20 million per 1 milliliter. Total sperm motility should be over 42%. Good luck if you're on anabolic androgenic steroids. That's the amount of sperm that's swimming around. Progressive motility, the sperm that's actually swimming in a straight line and not going in circles like Homer Simpson on the floor, should be over 30%. The non-progressive motility should be less than 1%. So that's the sperm that's swimming around but not getting anywhere. A motile sperm should be a maximum up to 20%, basically sperm that's not swimming. Sperm vitality, aka the viability, the sperm that's alive should be over 54%, and normal morphology should be over 4%. But if you use strict criteria based on other scientific evidence, that should be over 14%. We'll get more into this a little bit later on. And these fertility parameters aren't included in the updated guidelines by the World Health Organization, but I would still highly advise you to check these variables anyway, as they greatly help identify underlying problems and aid in the full recovery of your fertility parameters. The pH, the acid-basic balance of your semen, should be over 7.2 because the vagina is reasonably acidic. So the higher your pH is, the better it is to preserve the quality of your semen after ejaculation. A lot more on this a little bit later on this video. The viscosity should be normal, not too thick, and certainly not too watery, otherwise it would just basically leak out after ejaculation. Liquefaction should occur within 60 minutes. Again, more on this later. Semen mixed antiglobulin reaction test, the MAR test, detects the presence of anti-sperm antibodies, ASABs, in semen, and these antibodies can actually prevent conception by coating the surface of sperm, making it very difficult for them to reach and fertilize the egg. White blood cells should be below 1 million. Red blood cells should be negative. Round cells, again, red blood cells should be negative. And then DNA fragmentation, this is probably the most important part of the semen analysis, should be below 15%, indicating good DNA integrity. 15 to 25% is average sperm DNA integrity, and over 25% is poor sperm DNA integrity. We'll get into this a little bit later on when we discuss oxidative stress. And the semen fructose qualitative test, a normal result should be between 5 to 30 millimoles, which helps you identify problems when you're completely azoospermic. And this is very important to test on your first semen analysis after years and decades of blasting gear without human chorionic gonadotropin, right? It could be that you're completely azoospermic, zero semen in your semen sample to analyze, but then it's still very important to see if you have fructose content, which is being produced in the seminal vesicles. Because if you don't produce a lot of semen and you don't have seminal vesicles, you'll have structural issues. We'll address it a little bit later on. So there might be an issue with your seminal vesicles if your semen fructose content is 0, or an issue with your vas deferens, which is the area that allows for transport from the testicles to the seminal vesicles. So this can already determine any structural issues, which you can then further analyze with an ultrasound. So in your first semen analysis, make sure you check the fructose content of your semen sample. And it's basically the perfect segue. I also highly suggest you to do a testicular ultrasound at the start, around the same time that you did your first semen analysis, to assess if there's any structural issues in your testicles or the surrounding tissues. You might as well assess the health of your prostate while you're at it, right? You do one trip to the sonographer instead of multiple, because it's very important to know if there's any issues structurally with your testicles or the surrounding tissues. When you start throwing the kitchen sink of fertility medications at it, if there's a structural issue, it doesn't matter how much fertility medications you take, they're not going to end up in the testicles, allowing for sufficient spermatogenesis for super duper fertility parameters. Testicular and prostatic ultrasounds are non-invasive medical imaging tests that use sound waves to create detailed images of the sexual organs and the surrounding tissues. Do yourself and the sonographer a favor, shave and bathe well before the testicular ultrasound, and hold your urine for the prostatic ultrasound to get the best experience possible. Testicular ultrasounds can diagnose the following medical conditions: testicular tumors to differentiate between non-cancerous, benign, and cancerous, malignant masses; testicular cysts such as epididymal cysts or spermatoceles, which are fluid-filled sacs within the testicles. A hydrocele is fluid around the testicles. A little bit more on that later on. Testicular infections or abscesses, again, it can be identified using an ultrasound, whether that's bacterial or a viral infection. It can diagnose testicular torsion, which you would certainly notice through excruciating pain, as it's a medical emergency. This is the twisting of the spermatic cord, which cuts off blood flow to the testicles. So if you go in for a testicular ultrasound and you don't experience any pain, it's very unlikely that you experience testicular torsion. But if you had excruciating pain in your testicles years to decades ago, resulting in hypogonadism, there might be a permanent issue there because blood flow was cut off for a very long time. So again, testicular ultrasound is very important to do before you start conceiving, especially if you were hypogonadal in the past, before TRT and then some. Testicular orchitis, which is inflammation of the testicle, often associated with infections like mumps. Varicocele or varicoceles on both sides, enlarged veins in the scrotum that impair blood circulation and may affect sperm production and fertility parameters. If the blood flow is really impaired, then you require a Doppler ultrasound following the ultrasound to diagnose if you have a varicocele or varicoceles. Now, if you have a minor varicocele, they can actually do several gradations. Minor varicoceles don't require surgery because the blood flow to the testicles is still sufficient for normal fertility parameters and serum testosterone levels. But if the varicocele or celes is severe, then you probably need surgery. It can detect hydrocele or hydroceles, which is fluid accumulation around the testicles, not within, and hydroceles can still cause discomfort or swelling. Scrotal swelling differentiates between solid masses and fluid-filled areas causing swelling, detects inguinal hernias that extend into the scrotum. Undescended testicles help locate a testicle that hasn't descended into the scrotum. It's probably not an issue because that seems to be a common problem with, adolescents. But if you look down and you can't find your testicles, it's either from having an undescended testicle, a non-formed testicle, which is congenital, or excessive use of anabolic androgenic steroids, allowing the testicles to disappear within the body. And then if you go swimming in a very cold lake, then it makes it even worse. Testicular trauma detects injuries like ruptures or hematomas, aka blood clots, in or around the testicles. It can detect microlithiasis, which is the presence of tiny calcifications in the testicles. Sometimes that's linked to a higher risk of developing testicular cancer. And, testicular atrophy. Obviously, shrinkage of the testicles due to various causes, including an impaired hypothalamic pituitary testicular axis from steroid or SERM abuse. And again, while you're at it, do a prostate ultrasound if you haven't done that in a while to determine if you have benign prostate, hyperplasia, prostate abscesses or cysts, prostate stones, prostate cancer, prostatitis, ejaculatory duct obstruction, which is a blockage of the duct that carries semen, again, leading to male infertility, seminal vesicles, abnormalities like cyst infections or congenital defects, impairing your overall ejaculate quality, post-prostate surgery monitoring, and to assess the function of your bladder. Right, it's very important that you do both. I would highly suggest you do both at the same time. If you're diagnosed with any of the previously mentioned conditions, or you have another issue on your prostate or your testicles, please discuss that with a professional, right? That's what they're there for. The specialists know exactly what effect it might have on your overall fertility parameters, and if you need to go some sort of invasive surgical procedure to get everything fixed and resolved in order to get your partner pregnant further down the line, right? That's not what we're going to discuss in this video. That's what the doctors, the specialists, the professionals are there for. And again, to put your mind at ease, if you took human chorionic gonadotropin throughout the entirety of your steroid cycle or SERM cycle, it's very likely that your testicular size is exactly the same as where it was before starting androgen therapy, so to say, unless you were hypogonadal and your testicles were non-existent because LH and FSH levels were very low because of a pituitary or hypothalamus issue, right? Assuming you were healthy before starting steroids or SERMs, the testicular size doesn't really see much of a decline if you've been taking human chorionic gonadotropin throughout the entirety that you were blasting your socks off. I explain everything in the human chorionic gonadotropin deep dive. I would highly suggest you to give it a watch because human chorionic gonadotropin is an essential ingredient in this overall fertility protocol. I'll link it down below and at the end of this video. But you're not the only one who should do medical imaging to assess the health status of your reproductive organs. I would also highly suggest your partner to do a vaginal hysteroscopy, which is a diagnostic procedure used to examine the uterus and endometrium using a thin lighted tube with a telescope video camera called a hysteroscope. A vaginal hysteroscopy provides a detailed view of the uterine cavity and helps in diagnosing various gynecological conditions, including abnormal uterine bleeding, uterine polyps, uterine fibroids, congenital abnormalities, endometrial hyperplasia, endometrial cancer, intrauterine adhesions, uterine abnormalities, retained placental fragments, and aids in the removal of foreign objects, including intrauterine devices, which again should be removed, whether they are copper-based or hormonal-based, because intrauterine devices prevent your partner from getting pregnant. Again, you and your partner will need to discuss the results of her vaginal hysteroscopy with a gynecologist or another specialist to see if she's perfectly healthy or if she needs medical interventions before a successful implantation of a fertilized embryo can occur. A vaginal hysteroscopy is particularly important for women who took performance-enhancing drugs in the past, and whether those were anabolic androgenic steroids, selective androgen receptor modulators, or ancillaries like aromatase inhibitors or selective estrogen receptor modulators. All of these can have hormonal effects on the reproductive organs, which can have a negative effect on the uterine lining and thickness, making the chances of implantation rather difficult. PEDs can also result in amenorrhea, a temporary or long-term absence of menstruation, which might have a negative effect on overall fertility as well, even though the scientific evidence can be debated. Now, female fertility is a whole subject on its own, and the negative effects that performance-enhancing drugs have on female fertility are still poorly understood. I would highly suggest any female out there that took PEDs in the past to abstain from PEDs for at least 2 years, and make sure that they have a regular menstrual cycle for approximately 1 year to track ovulation cycles properly before attempting to conceive a child. Okay, so now both you and your partner have done the initial screening to assess if there's any structural issues with your reproductive organs, any issues with semen production, the menstrual cycle, or ovulation. Once that initial diagnosis has taken place, you can proceed with the remainder of this fertility protocol discussed in this video. For you, the next step is coming down to testosterone replacement therapy, removing all non-bioidentical hormones from your protocol, and using fertility medication to recover testicular function, unless you were already using human chorionic gonadotropin on cycle or alongside your TRT HRT protocol, in which case testicular function, testosterone production, and spermatogenesis was somewhat sustained. So during the next step, you're going to let all anabolic androgenic steroids, selective androgen receptor modulators, and their metabolites, which might be suppressive on testicular function, metabolize from your body, and then we're going to ramp up the fertility medication for spermatogenesis to get as high as possible. Here I'll provide all of the known and established half-lives of injectable steroid formulations, whether they are esterified or not, but I go a lot more in depth on how esters work and what their individual half-lives are in this video. Long story short, the half-life of an ester highly depends on the amount of carbon atoms that the ester contains and how readily these carbon atoms are cleaved off by the carboxyl esterases or the phosphodieesterases. That being said, the carrier oil in which the esterified steroid formulation is dissolved in also needs to be metabolized from the injection depot, and this seems to influence the half-life as well. Hence, for many of the steroids listed, there's a half-life range stemming from various studies using different carrier oils, examining how these esterified steroids metabolize from the injection depot in different studies. The active life of each steroid is approximately 5 times its half-life, which should allow for enough time for this anabolic androgenic steroid or selective androgen receptor modulator to metabolize from the body completely. But the metabolites might linger around for months, and the metabolites might have a long-term suppressive effect on the hypothalamic pituitary testicular axis and impair fertility parameters. So I've listed the clearance times of these metabolites under the evidence-based detection time, wherever known. Again, not all scientific evidence is available, unfortunately. Just keep in mind that the evidence-based detection time is based on single administrations, usually of several milligrams, maybe 5 milligrams, 10 milligrams, 50 milligrams at most, not hundreds to thousands of milligrams following consecutive administrations for months on end, you know, the kind of stuff we do in the bodybuilding space. So I would highly advise you to stick with the reported detection time that is stemming from athletes being subject to drug testing. When they discontinue a particular compound, let's say X months later, whether that's 5 months or 12 months or 18 months later, they beat a drug test. And that's how long it might take for these metabolites to clear from the system. Doing steroid cycles just means that the metabolites will build up over time, resulting in a much longer excretion period. And it means if you took decadurabolin at 1,000 milligrams weekly for, let's say, a couple months during your off-season, it might take 18 months before you can start improving your fertility parameters, because nandrolone is being produced in the body endogenously, being allowed to kept much higher than other metabolites, and thus the negative effect that nandrolone might have on your fertility parameters might take 18 months before that goes away. And then, and only then, can you really start seeing a significant improvement in your fertility parameters. Now, that doesn't mean that your fertility parameters can't come up during this time, but they will not be as stellar as having this nandrolone completely metabolized from your body, because progestogenic 19-testosterone derivatives have a quite tremendous negative effect on overall fertility parameters. So when I told you it was going to take months, if not years, this is one of the reasons why. And there's no information on the half-life, the active life, the detection time, whether that is evidence-based or reported on SERMs or injectable SERMs for that matter. So if you see a lot of unknowns in this list, my sincere apologies. This scientific evidence simply isn't up to par, and I haven't really talked to much people using SERMs and going or reporting a particular detection time, knowing that these SERM and their metabolites are completely metabolized from the body. So again, all the more reasons not to take SERMs. And if you go with the half-life of most injectable estroless steroids, suspensions like testosterone suspension, winstrol suspension, or perhaps trenbolone suspension, then the half-life of an injectable SERM might be anywhere alongside 24 hours with an active life approximately 5 days. The detection time of injectable SERMs might be anywhere between 3 weeks to 5 months, depending on how deep it goes into the injection depot and how long those metabolites linger in the injection depot. And again, these estimates are purely based on speculation and don't really represent how long these compounds might suppress your hypothalamic pituitary testicular axis and have a negative effect on overall fertility parameters. Still, caution is advised and give yourself adequate time for these metabolites to clear from your system. So here are the injectable androgen receptor agonists. We have boldenone acetate, boldenone cypionate, boldenone andesylate, aka equipoise, dihydroboldenone cypionate, aka DHB, drostanolone propionate, aka masterone, drostanolone enanthate, Methendienone suspension, also known as Dianabol depot, quite popular amongst the off-season bodybuilder protocols nowadays, it seems. Methanolone enethate, aka Primobolan, Nandrolone phenylpropionate, NPP, Nandrolone decanoate, Decadurbolan, oxymetholone suspension, also known as Androl depot, also very popular as an injectable pre-workout. Trembolone acetate, Phenaject, but that's used in animals. Trembolone enethate, Trembolone hexahydrobenzocarbonate, aka Parabolan, Treslone acetate, aka Ment, Treslone decanoate, testosterone suspension, Aquiviron, testosterone propionate, Testoviron, testosterone enethate, Testoviron depot, testosterone cypionate, depot testosterone, testosterone undecanoate, Nebido, and various testosterone blends, including Sustanon and Omnidren, and stanazolol suspension, aka Winstrol depot. Right, so all of the half-lives, the active lives, the evidence-based detection time, and the reported detection time wherever known were on the screen. You might have to pause that here and there so you know what to expect regarding the metabolism of these hormones. And here are the oral androgen receptor agonists: chlorodihydromethyltestosterone, CDMT, aka Turinabol, dimetazine, DMZ, fluoxymestrolone, halotestin, mestrolone, proviron, methendienone, dianabol, methastrone or methyldrostanolone, superdrol, methanolone acetate, primobolan S, mibelarone, check drops, oxandrolone, aka Anavar, oxymetholone, aka Anadrol, stanazol, winstrol, testosterone undecanoate, andriol, and you have LGD 4033, ligandrol, MK2866, ostrine, RAD 140, vocilosarm, S4, andrine, and YK11. Again, the details are all on the screen. Start with testosterone replacement therapy and give yourself adequate time for the metabolites to clear from your system. Now, minor fear-mongering aside, regardless of the compounds and the dosages you were using, from all of the fertility consultations that I've done over the years, I've seen that most men recover spermatogenesis and semen parameters start to improve within 3 to 6 months. That being said, it takes approximately 6 to 9 months before fertility parameters really start to shoot upwards. And in most cases, you need to come off cycle completely for fertility parameters to be super duper fertile. So let's rewind a little bit. From the day you decide to father children is the day that you decide to come off all non-bioidentical hormones and limit yourself to the following compounds: testosterone, any ester, with any injection frequency, any injection depth, whether that's sub-Q or intramuscular. I'll leave that entirely up to you. Dihydroepiandrosterone, DHEA, Pregnenolone, human chorionic gonadotropin, which is bioidentical in men, albeit that they produce it in trace amounts, right? Usually men rely on luteinizing hormone, but recombinant luteinizing hormone is very difficult to source, and if you can source it, highly expensive. So most men would stick with either urine purified or recombinant human chorionic gonadotropin in combination with either human menopausal gonadotropin containing urine purified human chorionic gonadotropin and follicle stimulating hormone, or recombinant follicle stimulating hormone, because again, urine purified follicle stimulating hormone is only found in human menopausal gonadotropin. So you go with either HMG or RFSH, and feel free to combine that with a therapeutic dose of growth hormone. That's always in the recombinant version, whether that's generic or pharmaceutical. A replacement dose of growth hormone or a therapeutic dose of growth hormone has been scientifically proven, especially in the elderly, people over 30 years old, that it helps with fertility parameters, both him and her. So I would suggest you to stick with recombinant human chorionic gonadotropin in combination with recombinant follicle stimulating hormone, based on all of the self-experimentation that I've done in order to get my wife pregnant. But again, cost, sourcing, and your response to these particular compounds kind of determine which compounds you're going to use for the next foreseeable months. With these bioidentical fertility enhancing drugs, you're going to aim to keep your sex hormones and your neurosteroid levels within the clinically accepted, albeit highly masculine, reference ranges. Beta human chorionic gonadotropin is below 5 milliIUs per milliliter because otherwise you would be considered pregnant. But if you take exogenous recombinant or urine purified human chorionic gonadotropin at 500 IUs 3 times per week, the day after a subcutaneous administration, your beta HCG levels will be approximately 12 to 15 milliIUs per milliliter. And after 1,000 IUs HCG shot, your beta HCG levels will be approximately, let's say, 22 to 27 milliUs per milliliter. So you know what to expect. If you go with the HCG route, right, all is discussed in the HCG deep dive, then beta HCG levels will be super physiological, which is not the end of the world, because luteinizing hormone, even though the masculine reference range is between 1 to 11 milliUs per milliliter, if you're on exogenous testosterone replacement therapy, LH is going to be 0. You need a human chorionic gonadotropin to replace the luteinizing hormone signal from the pituitary gland. Right, so beta HCG level will be super physiological, and LH will be well before clinically accepted parameters. Follicle stimulating hormone, the masculine reference range is between 1 to 13 milliUs per milliliter, and you can take a recombinant or urine purified follicle stimulating hormone coming from a human menopausal gonadotropin to bring follicle stimulating hormone levels up. So again, if you don't take HCG or FSH or HMG, your luteinizing hormone, follicle stimulating hormone, and beta human chorionic gonadotropin levels are going to be 0, and it means that fertility parameters are not going to improve. And I already know what you're going to ask me, Steve, can I use Clomid or enclomiphene? Blood clots. There's a lot of risk. We'll get into that a little bit later on. I would not suggest you to take Clomid and enclomiphene for months in duration, because the longer you stay on these SERMs, the more you risk getting a blood clot, right? Keep this in mind. That's why I would rather recommend you HCG and FSH instead of selective estrogen receptor modulators. Again, more on this later when we discuss post-cycle therapy, in case you need to come off cycle completely, because your fertility parameters are simply not improving by taking exogenous testosterone in combination with these fertility peptides. Total testosterone on the masculine reference range is between 250 to 1100 nanograms per deciliter. Free testosterone between 35 to 155 picograms per milliliter. Bioavailable testosterone between 40 to 257 nanograms per deciliter. Data testosterone DHT 12 to 65 nanograms per deciliter. Estradiol 10 to 40 picograms per milliliter. Sex hormone globulin between 10 to 50 nanomoles per liter. Dihydroepiandrosterone DHEA between 21 to 491 nanograms per deciliter. DHEA sulfate between 20.8 to 459.6 micrograms per deciliter. Pregnenolone between 53 to 357 nanograms per deciliter. Pregnenolone sulfate between 1 to 23 picograms per milliliter. And growth hormone between 1 to 10 nanograms per milliliter. Now, of course, some fluctuations are going to occur when you take exogenous testosterone, human chorionic gonadotropin, and follicle stimulating hormone, or HMG, but I would still advise you to stick as close as possible to these clinically established reference ranges, because that's what all of the scientific evidence is based on. And the more you go superphysiological, the higher you go, the more of these parameters go superphysiological, the further and further and further away you get away from the scientific evidence. And it might mean that it gets more difficult and more difficult to get your partner pregnant even after years of using these fertility medications. Oh, and as a comparison, before I forget, the feminist reference range that many Karen endocrinologists and general practitioners are trying to force down your throat without a reach around, you can see here that the total testosterone levels are 270 nanograms per deciliter less than the masculine reference range. So I'm still trying to throw you a bone here. If you go with general practitioners or Karen endocrinologists, you might bring your total testosterone level up to 830 nanograms per deciliter, but with a little bit of TRT in the mix alongside HCG, well, that's probably going to be too low for the majority of you guys. So feel free to do a comparison. I think that the masculine reference range is a good way to aim towards for the next couple of months. All right, so enough of that. Back to the reference range that we're going to use for this video. If you're using testosterone replacement therapy coming from steroid cycles, or you've been on testosterone replacement therapy the entire way through, again, like I mentioned before, luteinizing hormone and follicle stimulating hormone are going to be bottomed out because your HPTA is completely shut down if it wasn't shut down to begin with before starting TRT, because you needed it for medical purposes. But in an attempt to restore spermatogenesis, testicular function, and bring testosterone levels up, while simultaneously bring your exogenous testosterone levels down, right? The administrations can come down in dose and perhaps frequency. We're going to have to replace the luteinizing hormone signal with human chorionic gonadotropin. And based on the outcomes of the HCG deep dive, it seems that 325 IUs HCG subcutaneous or intramuscularly 3 times per week is enough to sustain testicular function while using exogenous testosterone, compared to baseline before exogenous testosterone was added to the mix. Again, this is in healthy individuals, not men suffering from hypogonadal states. And from 500 IUs HCG, either subcutaneous or intramuscular, 3 times per week onwards, it seems that you produce more intratesticular testosterone than you would normally from naturally occurring pulsatile luteinizing hormone signaling coming from the pituitary. So again, I would highly advise you to watch the HCG deep dive. We go a lot more in depth on how to use exogenous HCG at various dosages. So during this time that you're trying to recover testicular function, the dose of exogenous HCG 3 times per week, Monday, Wednesday, Friday, ideally, might be anywhere between 325 IUs up to 1,000 IUs. In order for you to sustain your masculinity, your sanity, your training intensity, your libido, and your overall quality of life, you're allowed, for now, to use a complementary dose of exogenous testosterone replacement therapy alongside the human chorionic gonadotropin and perhaps human menopausal gonadotropin or a recombinant follicle stimulating hormone to bring your total testosterone levels up to the quarter top of the reference range. And that means that total testosterone might end up anywhere between 880 to 1100 nanograms per deciliter. If you want to go to 1500 nanograms per deciliter, be my guest, but that's not what the scientific evidence is based on. So let's say you start with 325 IUs HCG 3 times weekly, a total of approximately 1,000 IUs HCG over the week, in combination with 150 milligrams testosterone, enanthate, cypionate, propionate, whatever ester you prefer, over the week, split over 3 injections. So you have 3 injections HCG Monday, Wednesday, Friday, 325 IUs every single time, and then 50 milligrams testosterone, any ester, in between those injections, Tuesday, Thursday, Saturday, or go with daily microadministrations, whatever you prefer, right? If the HCG is giving you, let's say, 400 nanograms per deciliter on your total testosterone level, and the exogenous testosterone is giving you an additional 600 nanograms per deciliter on your total testosterone, resulting in a total testosterone level of 1,000 nanograms per deciliter, that's more than enough to get the job done on all fronts. Regarding the use of aromatase inhibitors, there is some scientific evidence that letrozole and anastrozole are able to increase and improve sperm concentration, motility, and morphology in cases of subfertility. Regarding exemestane, it has been studied less in men compared to letrozole and anastrozole, but generally it has a mild positive effect on male fertility. But this scientific evidence wasn't duplicated in the context of using exogenous testosterone replacement therapy in combination with these fertility peptides. So if you come from a state where you never touched steroids or SERMs to begin with, then these aromatase inhibitors might be able to prevent the conversion of testosterone into estradiol. Estradiol causes the negative feedback on the hypothalamus and the pituitary, and thus luteinizing hormone and follicle-stimulating hormone levels go up, resulting in more testosterone, which again, you're preventing the conversion of testosterone into additional estradiol, which would otherwise have a suppressive effect. And when LH and FSH levels go up, and intratesticular testosterone levels go up and spermatogenesis is initiated to a greater extent, then overall fertility parameters improve. But this is not the sample group that we are. We shut down our HPTA with long-term steroid use. So in the context of this fertility protocol, I would rather not have you use aromatase inhibitors. Instead, bring your exogenous testosterone dose down to the point your serum estradiol levels are in range when you're combining the exogenous testosterone with human chorionic gonadotropin, which will produce estradiol directly in the testicles. Yeah, it sucks, but that's the way it's going to be, because even if you crush your serum estradiol levels to 0, it's going to take a very, 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 very long time for luteinizing hormone levels and follicle-stimulating hormone levels to come up, as long as you're taking exogenous testosterone, and then you might as well go with Clomid or enclomiphene. So aromatase inhibitors, in my humble opinion, off the menu. Just bring your exogenous testosterone dose down to give you a level of estradiol that is satisfactory to you. And keep in mind that serum estradiol actually helps with follicle-stimulating hormone receptor sensitivity. So when you take recombinant follicle-stimulating hormone or urine-purified follicle-stimulating hormone stemming from human menopausal gonadotropin, if you crush your serum estradiol levels to 0, the follicle-stimulating hormone receptor is not going to function correctly. And I hate to say this, but if you end up needing an aromatase inhibitor on a dose of HCG between 325 IUs up to 1,000 IUs 3 times weekly, with exogenous testosterone between 125 milligrams to 150 milligrams weekly, then you're just too fat, bro. And you need to get that bad butt under control, Mr. Chunky McChunk. If you have 1,000 IUs HCG and 150 milligrams testosterone intake per week, your testosterone levels will be super physiological. And even if your testosterone levels, total testosterone, is between 800 to 1,100 nanograms per deciliter, that's more than enough to make gains regarding fertility parameters, right? It's fertility enhancement protocol, not a performance enhancing protocol. If you're in the slight caloric deficit, it's not going to matter regarding your fertility parameters, but it is going to matter regarding your serum estradiol levels and your overall body fat levels. So if you're going to throw the HCG and the exogenous testosterone at it, if you're too fat at the start of this protocol, just get leaner so you don't need an aromatase inhibitor, which would otherwise potentially have a negative effect on your fertility parameters long term, right? What do you think is going to be more deleterious to your fertility? Being in a slight caloric deficit or having a super physiological testosterone levels? I'll leave that up to you. Ensuring that your serum estradiol stays around the quarter top of the reference range, let's say around 33 to 40 picograms per milliliter, similar to how total testosterone will end up at the quarter top of the reference range, seems to be ideal for your blood work parameters, for your libido, your cognition, your overall sense of well-being, and your fertility parameters. The use of 5-alpha reductase inhibitors has been linked to lower sperm count and lower sperm motility, albeit that these minor changes should not affect overall pregnancy outcome in men with normal semen parameters before they started finasteride or dutasteride treatment. So that's also in the context of not using exogenous testosterone, which shuts down the HPTA, impairing overall semen parameters. So if your semen parameters were already in the gutter, then I would highly recommend you to take the finasteride or dutasteride out because they have a minor negative effect on total sperm count and a minor negative effect on sperm motility, which is already impaired from the exogenous testosterone that you've been taking. So unfortunately, whatever your dietary testosterone levels end up being on TRT plus HCG, that's where it's going to be. And if that results in hair loss, too bad. Because finasteride, dutasteride, and perhaps even RU58841 might have a negative effect on your fertility parameters. And keep in mind that topical ketoconazole and minoxidil shampoo can also go systemic, which seem to have a negative effect on your overall sex hormone cascade and might also affect your fertility parameters. Now, regarding the systemic and negative effects of ketoconazole and minoxidil, RU58841, finasteride, dutasteride, aromatase inhibitors, and a lot of other compounds that might affect the sex hormone cascade, I already documented extensively in this video discussing why particular medications make you feel so bad, right? They might inhibit various steps of neurosteroid synthesis or sex hormone steroid synthesis, which ultimately downstream might impair fertility parameters. So you really have to be careful on what you take over the next couple of months. And this is why I tell you to stick with the bioidentical compounds only, because non-bioidentical compounds, especially medications, they can all have a negative effect on your overall fertility parameters. So personally, I do not recommend medical aromatase inhibitors or medical 5-alpha reductase inhibitors during this entire fertility protocol. But if you need to control your serum estradiol levels or your serum DHT levels for whatever reason, then stick with over-the-counter supplements, which you still need to do research on if they have a negative effect on male fertility, right? Watch this video discussing particular over-the-counter supplements which have a suppressive effect on serum estradiol levels, whether those inhibit the aromatase enzymes themselves or lower aromatase enzyme expression or lower estradiol levels through another pathway. Please do additional research. I cannot possibly research every single compound that's out there regarding their effect on male fertility. Your sexual binding globulin levels will slowly come up to match your intake of exogenous testosterone and your human chorionic gonadotropin protocol for normal conversion into estradiol. So I highly doubt you need to make any changes regarding your SHBG levels on this protocol. Regarding your DHEA and pregnenolone levels, you could supplement with exogenous DHEA or pregnenolone, or maybe the exogenous human chorionic gonadotropin is able to stimulate the production of these neurosteroids in the adrenal glands. Right? Blood work is required throughout the entirety of this protocol. So if you're young, you can probably rely on HCG, but if you're a little bit older, you might need exogenous DHEA and pregnenolone to bring your levels to the quarter top of their respective reference ranges. Now, however, the scientific evidence regarding DHEA and pregnenolone supplementation is rather inconsistent and inconclusive. DHEA supplementation can improve fertility parameters in cases of androgen deficiency and subfertility, which is also the case for pregnenolone supplementation, but that's mostly in the elderly. Now, it's very likely that you didn't supplement with DHEA and pregnenolone on cycle, so now it's a good time to start because DHEA and pregnenolone might contribute to your overall fertility parameters and improve your male fertility over longer periods of time. So unless you've been supplementing with DHEA and pregnenolone throughout the entirety of your steroid cycles or your TRT and HRT protocols, it is very unlikely that your DHEA, DHEA sulfate, pregnenolone sulfate levels are anywhere close to optimal. So feel free to start supplementing them in now to bring your DHEA, DHEA sulfate, pregnenolone sulfate levels up to the top quarter of the reference range, which I think is very beneficial for your overall sense of well-being and your fertility parameters, assuming that your total testosterone, your estradiol, and your direct testosterone levels are also towards the top quarter of the reference range. Just keep in mind that even a low dose of DHEA and pregnenolone can increase total testosterone levels and increase aromatization into estradiol or 5-alpha reduction into direct testosterone when you start supplementing these alongside your TRT plus fertility peptides protocol. So again, do your blood work frequently, start low, build your way up, and if you notice that total testosterone, estradiol, and direct testosterone levels are going super physiological, or you need an aromatase inhibitor or a 5-alpha reductase inhibitor by adding in DHEA and pregnenolone, then, bring your exogenous testosterone down a notch to maybe 100 milligrams weekly, because it's the HCG that's restoring the spermatogenesis and improving your fertility parameters, not the exogenous testosterone. It's the HCG that you need. So in this protocol, HCG comes first in combination with follicle-stimulating hormone or human menopausal gonadotropin, and the dose of your exogenous testosterone, DHEA, and pregnenolone might need to be adjusted based on your serum level. So again, blood work is key as part of this fertility protocol. Throughout the entire time that you came off non-bioidentical hormones on the day you decided to become a father to the time that you actually get your partner pregnant with a healthy baby, you need to avoid all of these drugs, these compounds, these medications, as they might have a severe to low negative effect on your male fertility parameters. And the list is very long and extensive, but might not be 100% all-inclusive. So again, please do your additional research if you take a compound that's not listed here. So here are the compounds, drugs, and medications to avoid: chemotherapy drugs, recreational drugs, anabolic androgenic steroids, albeit that testosterone is approved for therapeutic and medical usage and potentially induces spermatogenesis at higher dosages. And you see here that, Proviron and Halotestin were scientifically proven as fertility aids in cases of subfertility, again, stemming from the studies from the 1960s and 70s. So your mileage might vary. And you should avoid selective androgen receptor modulators, androgen and endocrine disruptors, including pesticides, industrial chemicals, dioxins, soy isoflavones, certain personal care product additives, natural androgen disruptors, heavy metals. You should avoid opioids. You should avoid selective serotonin reuptake inhibitors, which again might take a while to phase off and taper down from, because withdrawal symptoms can be brutal. I'm talking from personal experience. I came off fluvoxamine cold turkey. It was not fun. Calcium channel blockers you should avoid. Anti-androgens, obviously, you should avoid. Several immunosuppressants should be avoided. Sulfasalazine should be avoided. Non-steroidal anti-inflammatory drugs should be avoided. Amphetamines should be avoided, yes, including the medical ones like Adderall, Dexedrine, and Vyvanse. Not a good idea to take as part of your fertility protocol. 5-alpha reductase inhibitors should be avoided. And even Accutane and modafinil should be avoided. I cannot emphasize this enough. I cannot possibly research all of the medications, drugs, and compounds that you could possibly be taking. So write down a list of all the compounds that you are taking currently and do the research yourself on top of the research that I've already done for you to make sure that even if a compound has a marginal, trace, minute negative effect on male fertility, when you start stacking several compounds together, that might result into a tremendous severe negative effect on your male fertility. And then after 9 months, you're wondering why your fertility parameters are still in the trash because you're taking 5 compounds that you shouldn't be taking, even if it's occasional usage. So abstain as much as you can. Personally, I decided not to take any chances and just removed everything, literally everything that did not have a clear, established beneficial effect, even if it didn't have an established negative effect. And as you'll see from my fertility parameters a little bit later in this video, my fertility parameters were godlike. Yeah, so if you want something similar, abstain from everything that doesn't show to have a clear beneficial positive effect on male fertility, and you might get something similar. Now, enough of the stuff you shouldn't be taking. What should you be taking during the time that you're recovering spermatogenesis and throughout the entirety that you're trying to get your partner pregnant with copious amounts of practice? While you're recovering spermatogenesis, it's important to supplement with adequate micronutrients and antioxidants to improve testicular function, as testosterone and semen synthesis is a very nutrient-costly process. So here's the multi-phase testosterone synthesis and spermatogenesis recovery over-the-counter supplement, antioxidant, and method protocol. You do not have to do all of these at the same time. But the more of these you incorporate, the better your fertility parameters are going to be. And this obviously highly depends on how many micronutrients you're already getting from your diet. So go to Chronometer or another application where you can track your micronutrient intake for all of the foods that you're eating every single day. Feel free to supplement with vitamin B9, folate, folic acid between 100 micrograms to 1,000 micrograms daily. Feel free to go with the vitamin B50 or B100 complex to get all of the B vitamins as part of your supplementation stack. Vitamin C, ascorbic acid between 2,000 milligrams to 5,000 milligrams daily. Vitamin D3, cholecalciferol between 3,000 to 5,000 IUs daily. You can even break open the gel caps and apply the vitamin D3 directly to the testicles, which allegedly might help with testosterone synthesis and spermatogenesis downstream. Magnesium 400 milligrams to 1,200 milligrams daily. Vitamin E, mixed tocopherols and tocotrienols between 400 IUs to 800 IUs daily. Selenium between 100 micrograms to 200 micrograms daily for a maximum of 400 micrograms from dietary and supplementary sources. Zinc between 15 milligrams to 50 milligrams daily. Omega-3 fatty acids, that's up to, let's say, 3,000 milligrams EPA and 2,000 milligrams DHEA daily. Ubiquinol, coenzyme Q10, between 100 milligrams to 400 milligrams daily. Carnitine, whether that's oral L-carnitine L-tartrate or oral acetyl L-carnitine, between 2,000 to 3,000 milligrams daily, or injectable carnitine, 500 milligrams sub-Q or intramuscularly daily. Glutathione, you can go with N-acetylcysteine, 1,200 milligrams to 2,000 milligrams daily, or S-adenosyl methionine, abbreviated to SAMe, between 400 milligrams to 800 milligrams daily. Reduced glutathione, 500 milligrams to 1,000 milligrams daily. S-acetyl glutathione, 200 milligrams to 300 milligrams daily. Or injectable glutathione, 1,800 milligrams intravenously once weekly, or 600 milligrams intramuscularly 3 times weekly, right? You have to choose between one or the other because there's multiple ways to increase your glutathione levels. Same for nicotinamide adenine dinucleotide. You can increase that with a nicotinamide mononucleotide between 300 milligrams to 1,000 milligrams daily, or nicotinamide riboside, 300 milligrams to 1,000 milligrams daily, or injectable nicotinamide adenine dinucleotide, 100 milligrams to 200 milligrams IV once weekly, or 15 milligrams to 30 milligrams sub-Q or intramuscularly daily. Taurine, 3,000 milligrams to 5,000 milligrams daily. L-arginine, 2,000 milligrams to 6,000 milligrams daily. L-lysine, in combination with soy or sunflower lecithin. The L-lysine would be 500 milligrams to 1,000 milligrams daily, and the ideally sunflower lecithin, 3,000 milligrams to 5,000 milligrams daily. But L-lysine and lecithin only improve semen volume, not fertility parameters. But of course, the more semen volume you have, the more you can deliver the sperm to where it's supposed to go. You can ice your testicles. Yes. Increase the blood flow to your testicles filled with nutrients. I have a video about that. I'll link it somewhere down below. You apply an ice pack wrapped in a towel 20 minutes to your testicles 2 to 3 times daily. Again, this chills the testicles, and as it's chilling, once the ice pack is removed, it facilitates blood flow to the testicles to heat the testicles up again to the ideal temperature. And while the blood is flowing to the testicles, assuming you supplement with a good amount of the previously mentioned over-the-counter supplements and antioxidants, then this facilitates testicular function, testosterone synthesis, and spermatogenesis, especially if you take human chorionic gonadotropin and follicle-stimulating hormone or human menopausal gonadotropin. Everything is rushing in there, assuming you don't have a varicose cell, which should greatly help with your fertility parameters. And you can look into red light therapy, shining the red light directly on the testicles for 10 to 30 minutes once daily. Make sure your testicles don't get hot. They still have an ideal temperature. After a certain temperature, spermatogenesis is completely arrested. No hot tubs, no saunas. And if you do red light therapy, make sure maybe chill your nuts with an ice pack before you do the red light therapy for 10 to 30 minutes. And while sleeping at least 8 hours daily, sleeping and waking according to your circadian rhythm at the same time daily, greatly helps with testosterone synthesis and might contribute to fertility parameters as well. Again, not all of these supplements directly contribute to testicular function, testosterone synthesis, and spermatogenesis. There's a few supplements here which only contribute to semen volume. If you'd like to know more about massive loads, give the Vigorous Loads video a watch, which goes over everything you need to know to improve and enhance your ejaculation experience. Vigorous hypertrophy workouts or strength-specific training on steroids, even a low and conservative dose of exogenous testosterone replacement therapy, can increase oxidative stress markers as well, but we'll dive a lot more into oxidative stress when we get to the sex determination and differentiation, as well as the potential autism risk segment of this video. That being said, during all consecutive phases of this fertility protocol, it's very important for you to improve and increase your overall antioxidant status while recovering and improving spermatogenesis, as sperm morphology, sperm motility, and the chromosomes within the sperm are highly susceptible to oxidative stress. Okay, so we're probably already 1 hour into this fertility video. Let's proceed to phase 1. We're going to discuss how to recover spermatogenesis and fertility parameters on a TRT Plus protocol. Again, make sure you have the multi-phase testicular function supplements, antioxidant, and methods in place, which will continue throughout all of the phases of this fertility protocol. You can decide between any ester of testosterone, whether that's propionate, cypionate, enantate, undecanoate, or a cystanone blend. For example, just limit your weekly intake to, let's say, 125 milligrams to 150 milligrams, spaced out over various injections. If you go with 3 injections per week, let's say you do 42 to 50 milligrams sub-Q or intramuscular upon waking Monday, Wednesday, Friday, and then in between those injections, you go with recombinant human chorionic gonadotropin over urine purified human chorionic gonadotropin because the potency is so much better comparatively. And then you inject between 325 IUs to 500 IUs subcutaneously upon waking 3 times per week in between your testosterone injections on Tuesday, Thursday, and Saturday. Now, if you're in a hurry, feel free. Be my guest. By all means, increase your recombinant HCG dose to 1,000 IUs 3 times weekly, or 1,083 IUs to be exact, because the recombinant HCG pens, Merck Ovitrel, are 6,500 IUs. And if you split that over 6 shots, you get 1,083 IUs HCG per injection. But I can't say conclusively, based on all of the research that I did during the HCG deep dive, that more HCG regarding the recovery of spermatogenesis is better. So it highly depends on your finances. If you're really in a hurry, like if you took nandrolone decanoate and you need 18 months to let that metabolize before you can really expect solid fertility parameters, maybe start low at 325 IUs HCG and build your way up as needed as the nandrolone metabolites are clearing from your system. Because again, nandrolone has a suppressive effect on your fertility parameters. So why throw the kitchen sink at it early on when that would only result in a boatload of aromatization? Because, well, nandrolone promotes aromatization, unlike most of the other steroids. So again, start low and build your way up. But again, if you're in a hurry, feel free to go to 1,000 IUs HCG, and you might initiate spermatogenesis to a greater extent comparatively to a lower dose. I think you'll get more by the addition of recombinant follicle-stimulating hormone or going with urine-purified follicle-stimulating hormone stemming from human menopausal gonadotropin 3 times per week on the testosterone injection days, but at least in between your HCG injection days, instead of throwing the high-dose HCG at it. So a combination of HCG and FSH would be more beneficial regarding spermatogenesis than a higher dose of HCG solo. So if you go with recombinant follicle-stimulating hormone or urine-purified human menopausal gonadotropin containing FSH, you go with 75 IU sub-Q 3 times weekly, let's say Monday, Wednesday, Friday. This is optional, not mandatory during phase 1, but certainly a part of phase 1.1 in case phase 1 is insufficient after 3 to 6 months, maybe even 9 months if you decide to wait that long for spermatogenesis and fertility parameters to really shoot upwards. Again, if you want to get started with 1,000 IUs HCG 3 times per week and recombinant follicle stimulating hormone 75 IUs every single day of the week, be my guest. We'll discuss that a little bit more in depth when we get to phase 1.1. Therapeutic dosages of recombinant growth hormone from exogenous sources have been shown to improve overall fertility parameters in both men and women that are slightly older. So if you're, let's say, over 35 years old and you expect a little bit of difficulty because female fertility is impaired after 35 years old, feel free to introduce recombinant growth hormone, preferably pharmaceutical grade over generic growth hormone, at dosages between 0.2 to 2 IUs subcutaneously before bed to improve sleep quality daily. This mostly seems to be beneficial in elderly people who want to get their partner pregnant. I'm talking about people over 30 years old because, well, unfortunately, over 30 years old is elderly regarding fertility. After 30 years old, it just gets harder and harder and harder for conception to occur, especially in females, because the egg quality slowly goes down with age. So the chances of conception go down dramatically, and recombinant growth hormone might be able to help with that if you supplement with that, as well as your partner supplements with recombinant growth hormone. Unfortunately, I couldn't find any scientific evidence on growth hormone secretagogues. If they might aid in fertility, doesn't mean that's not the case. But again, I would go with the scientific evidence and choose recombinant growth hormone, whether that's pharmaceutical or generic, over growth hormone secretagogues. DHEA, dihydroepiandrosterone, anywhere between 25 to 50 milligrams daily over 2 servings upon waking and before bed. Pregnenolone, anywhere between 10 to 25 milligrams daily, split over 2 servings upon waking and before bed. And then if you need it, and if you're not morbidly obese and you have decent body fat levels, maybe diindolmethane, 100 milligrams upon waking and before bed, a total of 200 milligrams daily to control your serum estradiol levels by promoting the conversion into estrone. Again, when you take exogenous testosterone and human chorionic gonadotropin, your estradiol levels will be disproportionately higher compared to your estrone levels. So you can lower the burden of estradiol by promoting the metabolism into estrone. And if you don't want to take diindolmethane because you're convinced that it's an androgen blocker, which only has been proved in the context of prostate cancer, you can look into D-chiroinositol, which I used many a time at very high dosages, up to 3,000 milligrams daily. Did not seem to affect my serum estradiol levels, so that's why I didn't include it in this protocol. You can always go with aromasin, exemestane as your aromatase inhibitor, but please, even though aromasin has not been proven to have a negative deleterious effect on fertility parameters, it might actually improve fertility parameters, unless you're on testosterone replacement therapy. Please confirm your exogenous testosterone dose and the use of an aromatase inhibitor with monthly blood work until you're settled on this TRT protocol. Because again, if you were taking nandrolone or trestolone or Dianabol or whatever else in the past, as you're phasing into this phase 1 of TRT plus to initiate spermatogenesis, then as these hormones are tapering down, obviously you get additional aromatization, whether that's 7-alpha methyl estradiol, or additional estradiol. You probably still need an aromatase inhibitor to control your serum estradiol levels until everything kind of stabilizes and you can remove the aromasin or diindolmethane and use nothing at all. During phase 1, after let's say 3 to 6 months, maybe 9 months at maximum, you should be able to restore and improve your fertility parameters to the minimum that's required to get your partner pregnant, assuming she's young and healthy. Keep in mind that female fertility goes down with age. So if your partner is, let's say, between 18 to 25 years old, I don't think you need to come off exogenous testosterone and rely on human chorionic gonadotropin without the follicle stimulating hormone to get her pregnant. But if she's over 35 years old, it's very likely that you need to discontinue exogenous testosterone replacement therapy eventually and really hammer the fertility medications at it for your semen parameters to be as high as possible, because her fertility parameters are slowly going down and there's not much you can do about it, even with fertility medications. So again, if you're young, dumb, well, you guessed the rest. You probably don't need to come off exogenous testosterone in combination with HCG to get the job done. But if you're reasonably old from a fertility perspective, you probably need to remove the exogenous testosterone replacement therapy and rely on human chorionic gonadotropin at reasonably high dosages, follicle stimulating hormone every single day, growth hormone every single day, a complete and very extensive antioxidant stack, and then maybe also continue with the DHEA and Pregnenolone, because, well, as your fertility parameters slowly goes up, your need to reach a super high level to compensate for the lack of fertility parameters that your wife, again, that's slightly older from a fertility perspective, has. So depending on the scientific literature that you go with, here is an approximation of the chances of a healthy woman getting pregnant during each ovulation cycle, assuming that you have intercourse multiple times around ovulation. So if your partner is between 18 to 25 years old, she has a chance to get pregnant between 25 to 30% of the time. So that means within 3 to 4 attempts, aka 3 to 4 months, she should be pregnant, even on exogenous testosterone with just using human chorionic gonadotropin. If she's between the age of 25 to 35 years old, you have a 20 to 25% chance, meaning that you have 4 to 5 attempts, aka 4 to 5 months before she's pregnant. Age 35 to 40 years old is 15 to 20%, so you need 5 to 7 attempts. Age 40 to 45 years old, that's only 5 to 10%, so you need 10 to 20 attempts to get her pregnant. And the more attempts you need, the more she ages. So by the time you start, let's say she's 40 years old, after a year of trying, you went from a 10% chance to a 7% chance. Unfortunately, so as she ages, the chances get less and less and less. So you might be trying for almost 2 years. And then over 45 years old, it's less than 5% chances. So you need more than 20 attempts. By the time she gets pregnant, she's probably 50 years old, and going IVF is a much quicker route to get the job done. Depending on your fertility levels at the start of phase 1, which performance-enhancing drugs you were taking in the months leading up to phase 1, after 3 to 6 months on this fertility protocol of phase 1, maybe 9 months at maximum, you should be able to bring your fertility parameters to the following levels. These values are based on the lower end of the ranges of the 6th edition from the World Health Organization Manual for Human Semen Analysis, published in 2021, and a guesstimated average based on all of the fertility consultations I've done over the years. Again, there's a lot of variables in place, so these are just some guidelines. The abstinence time should be over 3 days, so you have enough semen volume, at least 1.3 milliliters. In many cases, with all of the fertility medications in place, that's 2 milliliters to 3 milliliters. Again, 1 milliliter of semen for every single day that you abstain on average. Sperm concentration should be over 12 million per 1 milliliter after 3 to 6 months on this fertility protocol. Total sperm per ejaculate should be over 35 million. In many cases, that's way, way higher. Total sperm motility should be over 40%. Progressive motility should be over 30%. But since you're still on exogenous testosterone, even with all of the antioxidants in place, it's very likely that at this point, after 3 to 6 to 9 months even on this fertility protocol, that your progressive motility is only between 5 to 20%, which is insufficient based on the statistics to get your partner pregnant, again, unless she's reasonably young. So even when semen volume and sperm concentration is well above the minimum, let's say 4 milliliters of semen volume and sperm concentration is over 50 million per 1 milliliter, if the progressive motility is, let's say, 5 to 20%, the fertility parameters are less than ideal. Non-progressive motility, again, will be about 1%, but in most cases, that's way, 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 way higher. Immotile sperm should be below 20%, but it will also probably be a lot higher. Sperm vitality and viability should be over 50%. That's usually pretty accurate based on this fertility protocol and all the fertility consultations that I've done over the years. Morphology should be over 3.9% normal forms. But again, due to oxidative stress while taking exogenous testosterone and training highly vigorously or doing strength training activity, you can expect a normal morphology of 1 to 2%. 4% is cutting it short. You should consider yourself highly lucky if your normal morphology is over 4% at this start of your fertility protocol. And again, if your progressive motility is super high and your normal morphology is super high, kudos to you. Your testicles are super healthy, and all of the performance-enhancing drugs that you took in the past did not take a deleterious toll on the quality of your sperm. pH should be over 7.2%. Viscosity should be normal. Liquefaction within 60 minutes. Semen mixed antiglobulin reaction. The MAR test should be below 50%, aka negative. white blood cells should be below 1 million, red blood cells should be negative, round cells should be negative, and DNA fragmentation should be below 25%, ideally below 15%. And again, the chromosomes within your sperm are highly susceptible to oxidative stress. So if your DNA fragmentation is really high, well, your antioxidant intake is not sufficient, and your oxidant intake from smoking, alcohol, etc. needs to be tapered down, removed entirely for your DNA fragmentation to be ideal below 15%. And the semen fructose qualitative test, again, should be normal between 5 to 30 millimoles. So again, if you're progressive, motility, your normal morphology in your DNA fragmentation isn't within or anywhere close to these parameters, you need to increase the dose of your fertility medication, proceed to phase 1.1, reassess your overall antioxidant intake, maybe lower your training intensity. I know it's a cardinal sin, but sometimes it has to be done. Remove all potential compounds that might exacerbate oxidative stress, or come off TRT entirely, still increase your antioxidant intake and remove your oxidative stress burden, and proceed to phase 2, 3, or 4, which we'll get into shortly. So like I alluded to earlier, phase 1.1 is simply a doubling of your fertility medications, and simultaneously you lower the dose of exogenous testosterone because an increase in fertility medications will ultimately result in more testosterone synthesis, estradiol synthesis, and diet testosterone synthesis. So if you want to keep your testosterone levels within the recommended masculine reference range at the top quarter, same for estradiol, same for diet testosterone. If HCG goes up, exogenous testosterone comes down, meaning that you lower the burden of oxidative stress slightly. Regarding if you're even a candidate for phase 1.1, it kind of depends on your finances, because doubling the fertility medications obviously means a doubling of your expenses, unless you buy in bulk and you get a bulk discount on your recombinant HCG and recombinant FSH. It kind of depends on where you started at phase 1. If you were completely azoospermic and your sperm count concentration was literally 0, then you probably started with phase 1.1 because you need to start a little bit more aggressively. And it kind of depends on the composition of your semen analysis. If your progressive motility, your normal morphology and DNA fragmentation values are in the gutter, then it's more an issue regarding oxidative stress compared to throwing the kitchen sink of fertility medications at it. But if you see that your semen volume, your sperm concentration, and your overall total sperm count is in the gutter, then you're a likely candidate for phase 1.1, where the fertility medications are literally doubled. And even though parameters that are susceptible to oxidative stress might be close to the recommended guidelines established by the World Health Organization in 2021, it's always good to reassess your antioxidant stack to make sure that these parameters are also coming up. And then over the next 3 to 6 months, as your fertility parameters are improving, that everything falls as close to the recommended guidelines as possible. So again, lower the burden of oxidative stress, whether that's training, smoking, drinking, etc., or particular compounds that induce oxidative stress, while increasing your antioxidant stack slightly. So phase 1.1, testosterone, any ester, but the dose is lower, 75 milligrams to 125 milligrams weekly, to compensate for the increase in recombinant human chorionic gonadotropin at 1,000 IUs to 1,083 IUs sub-Q upon waking 3 times weekly, in combination with recombinant follicle-stimulating hormone, or if you want, urine purified menopausal gonadotropin, 75 IUs sub-Q upon waking daily. Recombinant growth hormone is pretty much the same. Dihydroepiandrosterone, DHEA, is pretty much the same. Pregnenolone is pretty much the same. And if you need some sort of estradiol management, that can be incorporated in the form of dinomethane, dichloroinositol, or aromatase, if needed, proven with blood work. So be patient, give this protocol another 3 to 6 months, 9 months at maximum. Do semen analysis monthly to see how your semen parameters are improving month to month. And if you're not happy with your results and your partner isn't pregnant yet, then you'll need to proceed to phase 2, 3, or 4. So let me give you guys some insights on what to expect from a fertility protocol like this, using my own semen analysis results. This was my protocol leading up to the semen analysis, which I did on February 26th of 2023. I took all of the testicular function supplements, antioxidants, and methods. That was all in place. I took 156 milligrams testosterone enanthate coming from Bayer Testoviron over multiple administrations over the week. I took 1,083 IUs Merck Ovitrol recombinant HCG 3 times per week in between my testosterone injections. And then in between the Merck Ovitrol administrations, on the same day I would do testosterone administrations, ipsameronol, urine purified human menopausal gonadotropin, HMG, containing trace amounts of urine purified human chorionic gonadotropin, UHCG, as well as what we're after here, urine purified follicle stimulating hormone, UFSH, at a dose of 75 IUs subcutaneous upon waking 3 times weekly, Monday, Wednesday, Friday. 37.5 milligrams DHEA over the day, 12.5 milligrams Pregnenolone over the day, and my serum total testosterone levels ended up at 1400 nanograms per deciliter, which is 300 nanograms per deciliter too high, based on the established masculine reference range going up to 1100 nanograms per deciliter, and serum estradiol levels were 86 picograms per milliliter, which is, let's say, 200% out of the reference range. And here were my results. At first glance, they actually look very, very good, all according to the World Health Organization 2021 guidelines. But I didn't do a full examination because I just wanted to get a baseline reading after 3 months on TRT plus fertility medications. I did sex hormone testing and semen analysis at a clinic that's just around the corner of my house, which doesn't offer extensive semen analysis testing. So the abstinence time at the time was 4 days, and the semen volume at the time was 4 milliliters. I hope that semen didn't get into your eye. Sperm concentration was 75 million per 1 milliliter. Not too shabby. Total sperm per ejaculate, 288 million. Imagine if your army was 288 million soldiers strong. Total sperm motility, 76%. Very, very good. But I didn't check my progressive motility. I didn't check my non-progressive motility. I didn't check my immotile sperm, my viability, sperm vitality. I didn't check. The morphology based on this lab was 27%. pH was 8. Viscosity wasn't examined. The liquefaction was 29 minutes. So that's within 60 minutes. We didn't do a MAR test. But in this semen analysis, though, my white blood cell counts were out of range. This is the only bad result I got on my white blood cell count on the semen analysis results, which I've done extensively over the years. That's between 3 to 5 HPF. That stands for high power field. I'm not entirely sure how that translates to a certain amount of million white blood cells within a semen analysis, but 3 to 5 is considered high. All of the other results, it was between 0 to 1 HPF high power field. Red blood cells were 0 to 1 high power field, which is considered negative. Round cells didn't examine, DNA fragmentation didn't examine, and semen fructose qualitative test didn't examine because the total semen count was sufficient. So initially, you think that these results are pretty damn good. Then I came off the exogenous testosterone because I wanted to come off exogenous testosterone due to the potential for oxidative stress, proceeded to phase 2 of my fertility enhancement protocol, which we'll discuss a little bit later on. A month later, I went to a clinic that specializes in male and female fertility, and here are my semen analysis results a month later on March 26th of 2023. Here you see that after 3 months on TRT plus, phase 1.1, and 1 month without TRT, phase 2, abstinence time was still 4 days, but this time my semen volume was 3 milliliters, so a reduction of 25% comparatively to the previous semen analysis results. Sperm concentration dropped to 53 million per 1 milliliter. A month earlier, it was 72 million per 1 milliliter. Total sperm per ejaculate was 159 million, whereas previously it was 288 million. Total sperm motility dropped to 60%. A month earlier, it was 76%. Progressive motility this time was 17%. I don't know what the progressive motility was a month prior. Non-progressive motility was 43%. That's absolutely terrible compared to where it's supposed to be below 1%. Immotile sperm was 40%. Sperm vitality, aka viability, was 67%. So at least I was in range. Morphology was 4%, like I alluded to earlier, right? It's very common for normal morphology to only be 4% when you've been taking exogenous steroids plus human chorionic gonadotropin for months on end. And again, a month earlier was 27% though. So it's a significant reduction between both semen analysis results, but it could also be lab error, right? That's very common between a regular semen analysis at the clinic that doesn't really specialize in it to a semen analysis to a fertility clinic. Might be some discrepancy there, and the price discrepancy was also quite significant. The pH was 8, viscosity was high. It should be normal, but sometimes you're in a rush to get the job done, right? You only get like 10 minutes in the room to do your donation in the semen sample cup, so maybe I should have my wife present for additional foreplay. Liquefaction was normal. Mare test was normal. The white blood cell count was normal again between 0 to 1 on the high power fields. Red blood cells negative, round cells negative. Didn't examine the DNA fragmentation because at that time we weren't ready to start conceiving yet anyway. And DNA fragmentation tests is quite expensive. Semen fructose qualitative test we didn't examine because the total semen count was sufficient. Now I know what you're going to say, and in hindsight it makes complete sense. Steve, what about that study you started the video with? The study where you examined an animal model combining exogenous testosterone at a reasonably high dose with a supraphysiological level of luteinizing hormone and follicle-stimulating hormone, showing that semen parameters were very comparable to the baseline control group. And maybe that's what happened. By removing the exogenous testosterone, my total sperm concentration reduced from 72 to 53 million. My total sperm per ejaculate reduced from 288 to 159 million. My total sperm motility reduced from 76 to 60%. And my, morphology reduced from 27 to 4%. I guess we'll never know, dude. I guess we'll never know. But it could either be lab error. It could either be a tremendous amount of oxidative stress which occurred, which I don't think because I was on my full-blown antioxidant stack, and at that time I wasn't training that vigorously, even though I'm a vigorous Steve, so I should have been, but I knew I shouldn't be doing that. Or was removing the exogenous testosterone. Needless to say, at this point, I was pretty disappointed that my progressive motility and my normal morphology were below the recommended ranges, so I decided to go a little bit more aggressive on my antioxidant stack and double the recombinant follicle-stimulating hormone from 75 IUs 3 times per week to 75 IUs every single day. And keep in mind that during phase 1.1, I was using urine-purified follicle-stimulating hormone with trace amounts of human chorionic gonadotropin stemming from human menopausal gonadotropin. So from this change, you can clearly see that there's a significant increase in overall fertility parameters. And I'll show you those graphs a little bit later on in case you can't decide between phase 2, 3, or 4. So it might be that the discontinuation of the exogenous testosterone caused a steep decline in my fertility parameters after 1 month, but then doubling the follicle-stimulating hormone from 75 IUs 3 times per week to every single day saw a steep decline well beyond what I got from the exogenous testosterone plus fertility peptide protocol. So to reiterate, from this point onwards, if you're not happy with your fertility parameters and your partner isn't pregnant yet during phase 1.1, then you need to proceed and make a choice between phase 2, 3, or 4. Phase 2 means coming off all exogenous testosterone and neurosteroids replacement therapy and continuing with your fertility medications at double the dose, in which case the protocol is going to look like this. Again, the multi-phase testicular function supplements, antioxidants, and methods. Perhaps phase 2 additional testosterone and fertility boosting supplements and methods. We'll get into that when we discuss phase 2, 3, and 4. It involves ashwagandha root extract, tonkat ali, that kind of stuff. Testosterone in the ester is no longer allowed. You need to discontinue that. Recombinant human chorionic gonadotropin or a urine-purified human chorionic gonadotropin, but again, recombinant is way better. At 1,000 or 1,083 IUs subcutaneous upon awakening 3 times weekly, Monday, Wednesday, Friday. Recombinant follicle-stimulating hormone or urine-purified human menopausal gonadotropin, 75 IU subcutaneous upon waking daily. Recombinant growth hormone, if you do so desire. No more DHEA, no more Pregnenolone. And again, if you're a Mr. Chunky McChunk and you can't control your body fat levels, on this dose of exogenous human chorionic gonadotropin, your estradiol levels might still be elevated. So you might need diindolmethane, dichloroinositol, or even an aromatase inhibitor. So let's fast forward a little bit and give you an indication what you can expect from a fertility protocol like this. Phase 2 after 1 year. Here are my fertility parameters after 1 year on a phase 2 protocol without exogenous testosterone as part of a TRT plus protocol. Abstinence time was 5 days. Semen volume, 4 milliliters. Hell yes. Sperm concentration, 142.8 million per 1 milliliter, which is an increase of 269% compared to the first time I did a semen analysis on a phase 2 protocol. Total sperm per ejaculate, 571.2 million. Yes, per ejaculate. That's an increase of 359%. Nice work. Again, compared to the first time I did a semen analysis on a phase 2 protocol. Total sperm motility, 82%, an increase of 137%. Progressive motility, 76%, an increase of 447%. Non-progressive motility, 6%, a decrease by 86%. Immotile sperm, 18%, a decrease of 55%. Sperm vitality, aka viability, 89% of my semen was alive after 1 year without exogenous testosterone, which is an increase of 133%. Morphology, 43%, 43% normal forms. It's steep. An increase of 1,050%. Morphology, based on the strict criteria, 29%. It should be over 14% normal forms. I didn't test this at the beginning because it's included in the DNA fragmentation test, which I didn't do at the beginning because, again, I just wanted to get some baseline readings to see how far I was along and if I needed to go a little bit more aggressive on my fertility stack, which I did. And this is the result of it. When I started testing for semen DNA fragmentation 4 months earlier, according to the strict criteria, my normal morphology was 15%. And then over the course of 4 months, according to the strict criteria, my normal morphology increased to 29%. So that's almost double, an increase of 193%. So again, the longer you stay in a protocol like this, the better your fertility parameters are going to be. After 1 year without exogenous testosterone, the pH was still 8, so no improvements there, but I guess that's more than sufficient. Viscosity was normal, adequate time in the room where you need to give your semen sample. Liquefaction was 15 minutes. MAR test was still negative, below 50%. White blood cells 0 to 1, high power fields, red blood cells negative, round cells negative, and DNA fragmentation 6%. And again, below 15% is considered good DNA integrity. 4 months prior, it was about 15%. So that was already good when I did DNA fragmentation tests the first time. And 2 months prior, it was 17%. But that's, I think, after the trip to the United States. We'll get into that when we discuss the graph. So overall, it was a reduction over the course of 2 to 4 months of about 63%. And the last couple of semen analysis tests that I did, the DNA fragmentation was 6%. Yeah, it took me a year to get it that low. But I think you can do it faster because, again, I had to go through a lot of self-experimentation with antioxidants and fertility medications. But you don't have to because you have this awesome deep dive to present it to you on a silver platter. And all you need to do is spoon feed yourself. So these are the fertility parameters that you're looking for. I use this semen sample to fertilize 3 embryos through in vitro fertilization, one of which is already implanted in my wife and growing in her womb as we speak. And this semen sample and a previous semen sample are the ones that I froze for later use in case there's a nuclear apocalypse. And it's solely up to me to repopulate the planet afterwards. Yes, I have over 1 billion sperm frozen just in case. Too long didn't read. It took me 12 months to have godly fertility parameters on a phase 2 fertility protocol. Phase 3 means coming off the exogenous testosterone and neurosteroid replacement therapy and replacing your fertility peptide medications with either Clomid or enclomiphene, in which case the protocol is going to look something like this. You have your multi-phase testicular function supplements, antioxidants, and methods. Phase 3 additional testosterone and fertility boosting supplements and methods. No more testosterone. And then you're going to have to choose between either Clomid, aka clomiphene citrate, or enclomiphene, aka enclomiphene citrate. A dose used between 12.5 milligrams 3 times weekly, Monday, Wednesday, Friday before bed, up to 25 milligrams daily before bed, because that seems to mitigate some of the estrogenic side effects. And the dose highly depends on how responsive your hypothalamus and pituitary are to estrogen alpha and beta receptor blockade. Clomid and enclomiphene are selective estrogen receptor modulators and block the estrogen receptors in the hypothalamus and the pituitary, ultimately resulting over time, maybe weeks to months even, in an increase in luteinizing hormone and follicle stimulating hormone, which will go downstream and stimulate testosterone synthesis and spermatogenesis in the testicles, improving overall testicular function. But you might have a sustainable dip for months even if you were doing a phase 1 protocol or phase 1.1 protocol or maybe even a phase 2 protocol with these fertility medications. If you replaced LH and FSH with exogenous HCG and HMG or HCG and FSH, then during the time that these selective estrogen receptor modulators are restoring luteinizing hormone and follicle stimulating hormone levels from the pituitary, while there's a dip, there's obviously no testosterone synthesis and spermatogenesis. So that might mean that you have a 3 to 6 months delay before your fertility parameters actually get good and then better again. And again, during phase 3, you don't need any exogenous dihydroepiandrosterone or pregnenolone, or use dimethyl or exemestane to control your serum estradiol levels, because they'll be bottomed out. And even if your serum estradiol levels come up to a certain extent, then the selective estrogen receptor modulators in the form of Clomid or enclomiphene is blocking estradiol at the receptor site. The reason why I can't recommend a phase 3 protocol including selective estrogen receptor modulators for months on end, and prefer a phase 1, 1.1, or phase 2 protocol, including recombinant human chorionic gonadotropin and recombinant follicle-stimulating hormone, or the close alternative being urine-purified HCG and HMG, is because selective estrogen receptor modulators are linked to blood clots. And if you're going to use Clomid or enclomiphene for months on end, because your fertility parameters need to improve over several months, then you increase the risk of having a blood clot, deep vein thrombosis, pulmonary embolism, or other venous complications. There are several case reports showing that deep vein thrombosis occurs in as little as 15 days on 25 milligrams clomiphene, followed by 5 days on 50 milligrams clomiphene. So that's 20 days in total. And that's even shorter than commonly recommended post-cycle therapy protocols, including up to 100 milligrams clomiphene. Now, we don't hear so many issues regarding blood clots from selective estrogen receptor modulators use during post-cycle therapy treatments. But again, those last 4 weeks. If you're going to take Clomid or enclomiphene for months on end, your chances of a blood clot or venous complications steadily increases. And while there are only 90 studies performed on enclomiphene, which is one of the stereoisomers contained within clomiphene at approximately 62%, the other 38% is the stereoisomer zuclomiphene, where allegedly all of the terrible side effects of clomiphene are stemming from. So 2/3 enclomiphene and 1/3 zuclomiphene within enclomiphene. Going with the extract of enclomiphene at 100% of the dose, it shows great efficacy in hypogonadal men, increasing their luteinizing hormone levels, follicle-stimulating hormone levels, improving fertility parameters, and overall testosterone levels after a longer-term enclomiphene treatment. The phase 3 clinical trials did show a 0.5 to 0.35% chance of developing deep vein thrombosis or pulmonary embolism. So that's something you need to take into consideration. If these percentages are very low to you and you're willing to take the risk, be my guest. It's certainly a lot cheaper to go with selective estrogen receptor modulators over fertility peptides. It also comes with risk, and that's something you need to be aware of if you decide to go this route. That being said, there's a study showing that testosterone replacement therapy has a higher likelihood to cause deep vein thrombosis in hypogonadal men with other etiologies for deep vein thrombosis compared to clomiphene. You can find the citation down below in case you want to do a comparative scientific analysis. It wasn't worth it to me, otherwise I would have just used a cheaper option, went with enclomiphene therapy instead of exogenous recombinant HCG and FSH, which was significantly more expensive. Oh, and before I forget, SERMs are also known to cause estrogen-like effects in the brain, resulting in severe and tremendous emotional disturbances and irritability or instability, making the whole experience of getting your partner pregnant turn into a mental roller coaster. And by the way, what about the ocular changes and blurry vision that you might get on SERMs? Again, in case you haven't caught on yet, I don't like SERMs and I don't like SARMs. I think you should stick to the tried and proven bioidentical compounds that your body produces naturally for your fertility parameters to get as high as possible without tremendous side effects. Phase 4 involves an actual post-cycle therapy to recover your natural luteinizing hormone and follicle-stimulating hormone levels again, and let biology sort out the rest. Just be forewarned, 99% of the people will get fat during PCT because you go through noticeable lengthy periods of androgen deficiency, and the only thing that allows you to cope with it is copious amounts of calories. And if the PCT is going to take several months and you have several months of androgen deficiency, that's a lot of calories to keep you going. And to be honest, I would only consider a post-cycle therapy if you and your partner are still reasonably young, let's say below 30 years old, and you didn't need testosterone replacement therapy or exogenous testosterone because you were hypogonadal to begin with. You did a baseline check before you ever took steroids in your life, and your luteinizing hormone, your follicle-stimulating hormone, your testosterone, your estradiol, your dihydrotestosterone, etc., etc., etc. We're all within normal parameters, and perhaps you did a semen analysis as well, right? But Well, the large majority of the people just got it started with steroids haphazardly and didn't check their hormone parameters or their fertility parameters before they got started. So if you do have a baseline reading and you're still reasonably young, then yes, you may be able to get away with PCT because you'll recover your HPTA just fine. And then spermatogenesis a couple months later is more than sufficient to get your partner pregnant, who is also young. But if you were androgen deficient, your LH, your FSH, your testosterone, your estradiol, etc., were in the gutter and you needed TRT medically, then PCT is not a good idea. You can expect at least a 3-month downtime in improving your fertility parameters, even though initially they might improve when you start with selective estrogen receptor modulators like enclomiphene or tamoxifen, because both are able to raise luteinizing hormone and follicle-stimulating hormone levels, which contribute to male fertility tremendously. But as soon as you stop the selective estrogen receptor modulators, your LH and FSH do not have that much incentive to stay that elevated. So this is why there's a big difference between phase 3, where you continue with Clomid or enclomiphene for weeks to months to perhaps a year. Again, blood clots and ocular changes and emotional disturbances aside. A post-cycle therapy involves selective estrogen receptor modulators for, let's say, 4 to 8 weeks at maximum. So once your HPTA is recovered, LH, FSH, testosterone, estradiol, and the stimulatory effect that you get in your testicles regarding spermatogenesis takes a hit. And then it might take 3 months or even longer for spermatogenesis to start really ramping up and your fertility parameters to be noticeably better. So a post-cycle therapy will be the most lengthy approach of all of the phases that you can choose from. And again, you got to keep in mind that if you were on a hefty dose of testosterone with nandrolone to match with an 18-month detection time, then you might need to be on a TRT protocol or TRT plus protocol with HCG and HMG or FSH for close to a year to really let the nandrolone metabolize from your body, 18 months preferably. And then you need to discontinue the testosterone for, let's say, 4 to 6 weeks to let the testosterone metabolize. Then you need to stop the HCG, the human chorionic gonadotropin, and the follicle-stimulating hormone or the human menopausal gonadotropin for, let's say, 1 week. And then you can start post-cycle therapy. Yeah. Again, I'm not joking when I said it's going to take months, if not years. So like I said before, in order to prepare properly for phase 4 and have a successful outcome of your post-cycle therapy, discontinue the exogenous testosterone from your TRT plus protocol for at least 4, preferably 6 weeks to let the testosterone completely metabolize from your body. Stop the HCG, let's say 1 to 2 weeks before starting your post-cycle therapy. And the same can be said for FSH or HMG, right? You want your testosterone, your estradiol, your LH, your FSH levels to be basically bottomed out for the selective estrogen receptor modulators to do their job properly. So phase 4, the post-cycle therapy, includes the multi-phase testicular function supplements, antioxidants, and methods. The phase 4 additional testosterone and fertility boosting supplements and methods. You can still continue with recombinant growth hormone at a therapeutic dose of 0.2 to 2 IU subcutaneously before bed. This is the only performance-enhancing drugs that you're allowed to take during post-cycle therapy. Then you choose either between enclomiphene or clomiphene. Week 1 to 2, you take 25 milligrams to 50 milligrams upon awaking and before bed, a total of 50 milligrams to 100 milligrams daily. Then week 3 to 4, you should half the dose to either 12.5 milligrams to 25 milligrams upon waking and before bed. So that's a total dose of 25 milligrams to 50 milligrams daily. After which you should check your blood work parameters, because if testosterone, estradiol, and LH and FSH levels are not within the middle to the top of the reference range yet, then you probably need to continue post-cycle therapy for another 4 weeks. So week 5 to 8 might look like this, halving the dose again to either 12.5 milligrams to 25 milligrams, either enclomiphene or Clomid, before bed in a single serving once per day. And you might need to combine that the entire post-cycle therapy with tamoxifen, Nolvadex, which has a metabolite, norindoxaphene, which acts as an aromatase inhibitor. So if your estradiol levels were pretty high at the start of post-cycle therapy, then you might need some sort of aromatase inhibition in place to bring your estradiol levels down and allow for enclomiphene and Clomid to block the estrogen receptors and provide the highest luteinizing hormone and follicle-stimulating hormone signaling for proper testosterone synthesis and obviously spermatogenesis. And it also highly depends on how long your steroid cycles were and if you took significant time off in the meantime. So you might need to combine enclomiphene or Clomid with tamoxifen. Week 1 to 2 would be 10 to 20 milligrams upon awaking and before bed, a total dose of 20 to 40 milligrams daily. Week 3 to 4 would be 5 milligrams to 10 milligrams upon waking and before bed, a total of 10 milligrams to 20 milligrams daily, after which you should do your blood work, again, to check if testosterone, estradiol, LH, and FSH levels are towards the middle top of the reference range. And if that's not the case, based on another 4 weeks, week 5 to 8, 5 milligrams to 10 milligrams before bed in a single serving. After which, at week 8, your testosterone, estradiol, LH, and FSH levels should be middle to the top of the reference range. And if that's not the case, well, look into phase 2 or phase 3 instead. You can replace tamoxifen with exemestane, but there's no cookie-cutter answer for a exemestane aromatase dose. You need to do your blood work frequently to see that you don't crush your serum estradiol too low, because otherwise you're going to feel pretty freaking terrible throughout this entirety of the post-cycle therapy. And again, keep in mind that N-clomifene, Clomid, and tamoxifen can potentiate some estrogen-like effects in the brain. So if you get some emotional disturbances and it's a giant freaking roller coaster while you're watching movies, again, this was your choice, and now you got to see it through all the way to the end, right? When your partner is pregnant and you can start juicing again. After you finish your post-cycle therapy, it should take about 3, 6, 9 months for semen parameters to be really stellar. And during this time, you might still suffer from some sort of androgen deficiency, especially compared to where your testosterone levels were prior on TRT plus protocols or anything above like steroid cycles. So you won't feel too good. This is one of the reasons why I didn't do post-cycle therapy myself. I've done post-cycle therapy a couple times. My testosterone levels come back between 400 to 600 nanograms per deciliter. But in phase 2 fertility protocol, my testosterone levels are 800 to 900 nanograms per deciliter, and I feel 10 times better. During phase 2, 3, and 4, you can run the following additional testosterone and fertility boosting supplements, which should have a great synergy between the supplements we discussed previously, as well as the fertility medications like human chorionic gonadotropin, follicle-stimulating hormone, human menopausal gonadotropin, or various selective estrogen receptor modulators. So during phase 2, 3, and 4, you can decide on the following additional supplements: KSM-66 ashwagandha root extract, Tonkat Ali, Fedosia agrestis extract, Tuberculous terrestris extract, boron to bring your SHBG levels down, D-aspartic acid, fenugreek extract, castleberry extract, and maca root extract. Even though the last 4 are, negligible effects on testosterone production, but maybe if you combine all of them together in this stack, then testosterone might end up being maybe 900 nanograms per deciliter nonetheless. So look into these compounds individually and decide which ones you want to run alongside the fertility medications or the supplements which I discussed previously. You might get a marginal effect, which is noticeable in your overall libido, cognition, and training capacity while you're undergoing this entire fertility protocol, which again, might take months to years. So might as well leverage all angles. So if you're unable to decide between phase 2, 3, and 4, feel free to use my own personal anecdotal evidence regarding fertility parameters improvements over several months following either a post-cycle therapy or blasting my socks off with fertility medications all the way through. Here you see what my sperm count parameters look like for 9 months after finishing a post-cycle therapy. And besides the first month in October 2020, all of these values are above the guidelines established by the World Health Organization in 2021. So my fertility parameters improved as the guidelines were being published. At the 9th month mark, you see that sperm count really started to skyrocket. And at that time, my serum testosterone came up as high as 680 nanograms per deciliter. And my LH and FSH levels were around the bottom middle of the reference range, even though they were middle top to the reference range while taking SERMs. So between, let's say, October 2020 to August 2021, a steep increase in my sperm count parameters, ending up with a sperm concentration of, let's say, 125 million per 1 milliliter, ending up with a total sperm per ejaculate around 350 million. And here you see my sperm count parameters during a total of 15 months of recombinant human chorionic gonadotropin and recombinant follicle-stimulating hormone therapy, which is already following several months of TRT+, which also included urine purified and recombinant human chorionic gonadotropin, as well as human menopausal gonadotropin containing urine purified follicle-stimulating hormone. After 9 months, most parameters were very comparable to 9 months after finishing the post-cycle therapy. We'll compare that head-on-head a little bit later on, albeit that at the 15-month mark, parameters were significantly higher. Now you can clearly see a steep dip in the graph around mid-November 2023, and that's when I went to the United States for an entire month. I wasn't able to keep up with my full fertility protocol during this time. I smoked a couple of cigars, drank a little bit of alcohol, ate out way too much, and it took me a few months to recover from that work/holiday trip. So during your fertility protocol, don't misbehave. Right? This is why I mentioned that you should abstain from certain things, because when I came back from the United States and I did my semen analysis, almost a 50% reduction. And it took me a while before I came back to the previously stellar fertility parameters. So when we start comparing between post-cycle therapy and fertility peptide therapy, at the 9-month mark after post-cycle therapy, semen volume was 3 milliliters, sperm concentration per 1 milliliter was 120 million, total sperm per ejaculate 360 million, total motile sperm 270 million, and motile sperm per 1 milliliter 90 million. Very comparable to 9 months on R-HCG and R-FSH therapy. Semen volume 3.5 milliliters, so you get half a milliliter more. Abstinence time between post-cycle therapy and this fertility peptide therapy was exactly 4 days. So you get a little bit more semen while you're using these fertility peptides. Sperm concentration per 1 milliliter was 116.4 million, so that's 4 million less almost. Kind of disappointing. But total sperm per ejaculate was 407.3 million, so that's almost 50 million more. Total motile sperm was 325.8 million, so that's also, let's say, 50 million more motile sperm. And motile sperm per 1 milliliter was 93.1 million, so that's almost the same. But after 50 months of R-HCG and R-FSH therapy, you see a significant increase. So a little bit longer means much better semen parameters. Semen volume on a 4-day abstinence time was 4 milliliters. Sperm concentration per 1 milliliter was 142.8 million. So that's another increase of 30 million per 1 milliliter, with a total sperm per ejaculate of 571.2 million. Epic. Total motile sperm was 468.4 million. Imagine that much motile sperm invading. Yeah. And the motile sperm per 1 milliliter was 117.1 million. So that's a significant difference between post-cycle therapy and R-HCG and R-FSH. But again, I don't know what my semen parameters would have looked like if I abstained from anabolic androgenic steroids and then some for another, 6 months after finishing that PCT, because I was very eager to get back in the gym and start kicking some ass again. So based on these results, you'd say that you should be able to start conceiving 9 months after finishing a post-cycle therapy, which is ultimately a lot cheaper and doesn't involve daily injections. Wrong. There's a clear difference in semen motility and semen morphology when you rely on naturally produced luteinizing hormone and follicle stimulating hormone. Again, in my case, it was in the bottom middle of the reference range. That might not be the case for you individually if you're still reasonably young. I was 37 at the time. So I decided to go with recombinant human chorionic gonadotropin and recombinant follicle stimulating hormone therapy, which brought my beta-HCG levels to supraphysiological levels and kept my FSH levels in the middle of the range. So here you see in the graph the semen motility and morphology 9 months after finishing a post-cycle therapy. Well, actually, the entire way through of finishing a post-cycle therapy and 9 months later, progressive motility and morphology is in the gutter. It's so low that the lines are overlapping. I started with a progressive motility and morphology, let's say around 1 to 2%, and ended up at 4%. 9 months of waiting for progressive motility and normal morphology to come up, nothing. And I was on a comparable antioxidant stack, doing everything right for the best testosterone synthesis and spermatogenesis within my testicles. But my endogenous LH and FSH was just not up to it. Even though immotile sperm came down significantly from, let's say, 80% to ending up at 25%, give or take. That's not what we're after. We're after the increase in progressive motility of the semen, as well as normal morphology of the semen. So we compare that to the semen motility and morphology during 15 months of fertility peptides therapy. Again, the first month that I tested it was not at a suitable lab. So let's start at the second month, somewhere in March 2023. After removing the exogenous testosterone, my morphology was reasonably low, let's say 4%. And then it steadily went upwards to approximately 42% 15 months later. And same with the progressive motility that started low at, let's say, 18%, and then steadily increased, minus the holiday to the United States, to, well, what is it, 75%, give or take. We have the actual data a little bit later on. So clear differences. Clear differences between relying on natural endogenous LH and FSH or relying on exogenous RHCG and RFSH. So here are the direct comparisons for sperm motility and sperm morphology. 9 months after finishing a post-cycle therapy, total sperm motility was 75%, but 9 months during recombinant HCG and RFSH therapy, my total sperm motility was 80%. Big difference. Progressive motility, 4% versus 68%. Gigantic difference. Non-progressive motility, comparing 71%, which is very, very high, to 12%, which is almost where you want it to be. Immotile sperm, 25% versus 20%. Sperm vitality, aka viability, 78% versus 86%, so that's still reasonably close. Normal morphology, 4% versus 35%. And morphology, according to strict criteria at the time, was 24%, but I did not check that after finishing a post-cycle therapy and relying on endogenous LH and FSH. Now, we fast forward a little bit, 15 months of RHCG and RFSH therapy. Total sperm motility was 82%, so that's a little increase compared to the 9-month mark. Progressive motility, 76%, so it's another increase. Non-progressive motility reduced to 6%. Immotile sperm reduced to 18%, minor changes. Sperm vitality, aka viability, increased to 89%. Normal morphology was 42%, but according to strict criteria, normal morphology was 29%. Again, that's double over where they recommended it to be. It should be over 14%. And DNA fragmentation ended up being 6%, which is very, very low, which is a good thing. So if you want to take it from me, right, a person, an N of 1 anecdotal experience doing copious amounts of semen analyses, way more than most people do, right? Comparing a phase 2 protocol involving fertility medications versus a phase 4 protocol doing a post-cycle therapy and then relying on endogenous LH and FSH, I would go with phase 2. I would 100% go with phase 2, even though it's significantly more expensive. You'll feel better, you'll look better, you'll be able to train harder, and your fertility parameters will be godlike. Godlike. And that's ultimately what we're after, right? Now, big difference aside, obviously there's still a lot of variables in place. Different phases of my life, 37 to 38 years old, 40 to 41 years old, different compounds being used, different stressors perhaps. And well, unlike you, I didn't have a video like this to design a fertility protocol with. So maybe you can get the job done a lot faster and don't need so many fertility medications, but I had to go through self-experimentation, which you don't have to. All of that aside, it's very important for you to do a monthly semen analysis. So you can keep track of how your semen analysis and fertility parameters are improving. Because if you don't see steadily improving parameters from month to month, then your protocol probably needs some adjustments. And just because I got stellar fertility parameters by the end of my protocol doesn't mean that you will. And just because you don't have stellar fertility parameters after months of trying to improve them to the highest possible you can, doesn't mean you can't get your partner pregnant. I mean, look at my fertility parameters. After 15 months of trying naturally around ovulation multiple times, we decided to go with in vitro fertilization. And perhaps that's because my wife is a little bit older. She was 40 at the time that we really tried to conceive very, very, very actively. Very enjoyable periods nonetheless. But yeah, after months and months and months of trying and seeing negative results on the pregnancy test, we decided to go with IVF. I mean, I know bodybuilders that got their partner pregnant on cycle, a proper bodybuilding cycle containing everything under the sun with a total sperm per ejaculate of only 6 million, not per milliliter, per ejaculate, just 6 million, with a progressive motility of, let's say, 5% and a normal morphology of only 3%. And their baby is healthy, just the same. Beautiful child, growing up normally, no complications. But you and me both know that all of those children, or a large majority of them, are girls. So again, on the topic of sex determination and sex differentiation, let's get into oxidative stress. So let's dive into this commonly reported higher likelihood of having a daughter compared to a son, where you're trying to conceive a child during a steroid cycle or even after you've discontinued steroid usage. And this effect is observed anywhere from TRT and upwards and doesn't seem to be dose dependent. Men using steroids, whether that's TRT or thereabove, appear to have a higher chance of conceiving a daughter. So if you love steroids, I also hope that you love playing with Barbies or applying makeup. And if you're more a kind of guy that likes to tinker with cars or play masculine sports, high contact sports, for example, you're going to have to let the steroids go for a while, buddy. To explain this observed effect and ways to potentially circumvent it, you need to understand the difference between the male Y chromosomes and the female X chromosomes. Males have one X chromosome and one Y chromosome, but the Y chromosome is much smaller than the X chromosome and contains fewer genes, many of which are specific to male development and responsible for initiating male sex differentiation during pregnancy. Females have two X chromosomes, one of which is generally inactivated in all cells of the body. This inactive and condensed X chromosome found in the nuclei of female cells is also known as the bar body X chromatin or sex chromatin. The inactivation prevents overexpression from X-linked genes. However, the inactivation is not always complete. Some of the genes actually escape inactivation and contribute to cellular function. So the cellular function of females is different from males due to the difference in chromosomes. The male Y chromosome has fewer mechanisms to repair DNA damage due to its smaller size and lack of homologous pairing with a matching Y chromosome during meiosis. Males are XY, not YY, so you don't have a backup, so to say, like females do, with an X and X chromosome. This makes the Y chromosome more susceptible to mutations or loss of function under oxidative stress. Oxidative damage to the Y chromosomes can impair male fertility, reducing sperm count, reducing motility, reducing morphology and viability, and severe damage to the SRY gene on the Y chromosome can result in failure of male sex differentiation. So that basically means that if you're undergoing a lot of chronic oxidative stress, your sperm is now handicapped, and through somehow, some way, some magical cosmic event, your sperm with limited swimming capacity and weird morphology is able to reach the egg, penetrate it, and deliver the Y chromosomes, then it probably doesn't result in a healthy embryo. And even if you do get an embryo, it might not implant. And even if it does implant, well, it's very likely that you have a miscarriage. And it's also because the female X chromosomes, being larger and present in duplicates in the cells, have redundancy, aka a backup. If one of the X chromosomes is damaged, the other can often compensate, which makes a female generally more resilient to genetic issues. And if your sperm delivers an X chromosome and your partner has an X chromosome, backups. But with the Y chromosome, unfortunately, there's no backup. So that means a lower likelihood of transporting that properly and fertilizing an embryo for a healthy baby. Immature sperm cells, being spermatocytes or spermatids, have underdeveloped antioxidant defenses, making them more susceptible to oxidative damage. Spermatogenesis within the seminiferous tubules in the testes can take approximately 64 to 78 days, let's say about 2 to 2.5 months. The epididymitis secretes antioxidants to protect sperm, but imbalances between reactive oxygen species and antioxidants can still occur. Sperm maturation within the epididymitis takes approximately 2 to 3 weeks, let's say around half a month. Semen is stored for several days to weeks within the epididymitis and to a certain extent within the vas deferens, albeit that semen mostly passes through the vas deferens on the way to the seminal vesicles. Prolonged semen storage without ejaculation can lead to sperm aging and oxidative stress within the epididymitis and the vas deferens, reducing sperm quality and overall fertility parameters. And this is one of the reasons why no-fap semen retention is such a terrible idea for fertility. Ideally, during the entire time that you're trying to improve your fertility parameters, you should ejaculate at least 3 times weekly. And it doesn't matter where you ejaculate. All that matters is that you ejaculate frequently, let's say every other day or 3 times weekly at minimum, to minimize oxidative stress to the semen and ensure that you have the highest possible progressive motility as well as normal morphology percentages. Once you're ready to conceive, you can switch to every other day inseminations or daily inseminations around the time of ovulation. More on this later on. Semen transport to the seminal vesicles and ultimately the oh so enjoyable Ejaculation usually only takes seconds to minutes, after which it can either attempt to fertilize an egg following ovulation or end up in a semen sample cup ready for analysis. And for the sake of this video, we'll forgo all potential fates of semen after ejaculation. I'm sure you can use your imagination and come up with a couple scenarios. Oxidative stress can still occur within the seminal vesicles, the prostate, and the Cowper's gland, which all contribute fluids that produce semen. And while seminal fluid contains high levels of antioxidants that protect sperm from reactive oxygen species during transport and ejaculation, oxidative stress can still occur within these glands, reducing semen quality. The Cowper's gland contribute neutralizing pre-ejaculatory fluid, which helps protect the semen during ejaculation. However, insufficient secretion can leave sperm vulnerable to oxidative stress. And if that's not bad enough, exposing the semen to residual acidity from urine left in the urethra can further cause oxidative stress. So long story short, wash your junk thoroughly and practice some foreplay before you ejaculate. So don't turn it into a 3-minute affair. Take your sweet time for the oxidative stress to be minimized. And again, oxidative stress can also affect progressive motility and normal morphology of sperm. If you're undergoing a lot of oxidative stress currently, then you can expect low progressive motility, low normal morphology, and high DNA fragmentation on your semen analysis results, indicating a very, very, very low chance to conceive, whether that's a boy or a girl. The sperm themselves also have limited DNA repair mechanisms due to their condensed chromatins being in a transcriptionally inactive state. Sperm carry either a Y chromosome or an X chromosome, so you could say that sperm is either male or female, not both and nothing in between. The female egg only carries the X chromosome, not the Y chromosome, so a female egg is always female until a male sperm delivers a Y chromosome for sexual differentiation. Under conditions of high oxidative stress, whether that's in the male or female or both, the proportion of Y sperm, Y chromosomes reaching the egg may decrease, favoring the conception of a female XX offspring. So it's almost 100% up to the father to produce a male offspring, but certainly 100% up to him to provide a Y chromosome that has been produced under a low oxidative stress environment in order to increase the chances of conceiving a boy with his partner. And that being said, once the male sperm with Y chromosomes enter the vagina and uterus, but there's a lot of reactive oxygen species present, then these male sperm with Y chromosomes might not reach the female egg with X chromosomes, allowing for normal fertilization to occur. So again, you need to be under low oxidative stress environment for at least 3 months for the semen to be normal and a higher chance for Y chromosomes to end up in the female egg. And for her, she also needs to be under the low oxidative stress environment throughout the entire time that the egg is maturing, and certainly for the 9 months after she gets pregnant until she gives birth, and even after giving birth during breastfeeding, low oxidative stress environments. Managing oxidative stress is highly important for both partners. You know what increases oxidative stress the most in bodybuilders or general fitness enthusiasts? Steroids plus exercise. And which ones of these are you willing to give up or at least reduce to the point that oxidative stress is completely minimized in order for you to conceive a son with your partner? Now, there is some conflicting scientific evidence regarding the use of exogenous testosterone replacement therapy and its effect on oxidative stress, or if it actually protects against oxidative stress. In this study performed by Christensen et al. Titled Whole Body Oxidative Stress Reduction During Testosterone Therapy in Aging Men, a randomized placebo-controlled trial, you see that exogenous testosterone replacement therapy was shown to reduce whole body oxidative stress in obese elderly men over 67 years old, which was attributed to the improvement in body composition. So is that the testosterone replacement therapy or just following a better lifestyle? And well, we could say that obese elderly men over 67 years old should not really attempt to conceive again. Unfortunately, I couldn't find any scientific evidence that shows that oxidative stress occurs within the testicles of humans while using anabolic androgenic steroids, again, where most of the oxidative stress on the semen occurs. But there are some in vivo studies and animal models which show exactly that. This has been confirmed for the following compounds. If I couldn't convince you with the steroids versus fertility video, maybe I can convince you now. Here's the list of steroid-induced impaired fertility and testicular oxidative stress or injury. With testosterone, it has antioxidant and anti-inflammatory properties in oxidative stress induction animal and in vivo models. So if you're undergoing high oxidative stress and you identify as a cell in a petri dish or an animal, then exogenous testosterone might actually offer antioxidant and anti-inflammatory effects. Exogenous testosterone restores spermatogenesis in oligoastenospermia, stemming from an animal model which we discussed at the start of this video. So use the timestamps to skip back, almost 2 hours. And exogenous testosterone decreases antioxidant defenses in healthy animals. So again, conflicting scientific evidence. Does it cause oxidative stress or not? I'll leave it up to you to follow the citations and make a decision going forward. Exogenous estradiol, coming from estradiol benzoate, worsened oxidative stress when combined with eccentric exercise. Nandrolone, stemming from decadurabolin, worsened oxidative stress when combined with swimming exercise, which was ameliorated by taurine and melatonin, which are very potent antioxidants. Oxymetalone, aka anadrol, causes oxidative stress in the testicles and impairs fertility parameters, but that can be ameliorated with royal jelly or watercress and Caucasian whortleberry hydroalcoholic extracts, again, which are all high in antioxidants. Boldenone equipoise causes oxidative stress in the testicles, as well as stanozolol winstrol causes oxidative stress. So all of these you should avoid. And if you want to dive deeper into the potential benefits of exogenous testosterone regarding oxidative stress, you're welcome to do the research, but I would still highly recommend you to discontinue it. And even if you don't take steroids, oxidative stress markers might still be slightly elevated if you're a bodybuilder or you train vigorously. This study performed on bodybuilders that didn't take steroids, performed by Selig et al. From October 20th, 2024, so that's very, very new, titled Assessment of Paraoxinase 1 and Aryl Esterase Activities and Lipid Profile in Bodybuilders, a comparative study of physical activity and anthropometry on atherosclerosis. This study shows that unless bodybuilders supplemented with antioxidants, that oxidative stress markers are also elevated, again, in bodybuilders that train vigorously. Oxidative stress was considerably higher in high-intensity resistance-trained bodybuilders compared to those who performed moderate-intensity resistance exercise, which has been shown to increase antioxidant status in otherwise normal, healthy individuals. So again, if you're a bodybuilder that trains vigorously, maybe take that down a notch from high-intensity exercise to medium-intensity exercise. And if you're on steroids, which are known to cause oxidative stress, bring it down to TRT, like I've been saying this entire video. The benefits of moderate intensity resistance exercise regarding the reduction of chronic oxidative stress markers and an improvement in overall health parameters has been well established. This average gym-goer level of intensity strengthens the body antioxidant defenses and reduces the risks of oxidative damage over time. Self-testosterone replacement therapy reduces oxidative stress potentially, or at least in aging men it does, and moderate intensity resistance training strengthens the body's antioxidant defenses. Then why not combine both, you might ask? And yes, it makes absolute total sense, but I couldn't find any scientific evidence to support that otherwise healthy men running testosterone replacement therapy or hormone replacement therapy and training with moderate intensity exercises have an improved antioxidant status and increased antioxidant defenses. If the previously discussed TRT plus fertility peptides phase 1 or phase 1.1 protocols with all of the antioxidants that you feel comfortable with are not getting the job done, improving your overall semen parameters, then you need to proceed to either phase 2, 3, and 4, reassess your antioxidant intake, reduce your training intensity, or maybe both. Again, assuming that you want a son without autism. But if you want a girl, then you might be able to get the job done with a phase 1 or phase 1.1 protocol where you keep the exogenous testosterone in place running the fertility peptides, which I already discussed. Just make sure that you still stay on top of all of the antioxidant supplements and reduce the burden of oxidative stress so your DNA fragmentation is very, very low and the overall quality of your semen is very, very high. That still not mitigates the fact that your daughter might have autism. So let's address that here in this segment of this video. Keep in mind that there's a clear correlation between oxidative stress in both parents, whether that's the father, the mother, or both before and during pregnancy and autism. So besides the higher likelihood of bodybuilders having daughters, there also seems to be a disproportional amount of bodybuilders having children that are autistic. So I felt it's only fair to address it here while we're on the topic of oxidative stress. I would highly advise you to watch the podcast between Dr. Peter Attia and Dr. Tren Sutcliffe. It's linked down below, right below the Humor Room podcast, discussing all kinds of fertility aids. I'd watch both if you're interested in conceiving a child in the future, after you're done watching this video, obviously. The podcast with Dr. Peter Attia and Dr. Tren Sutcliffe is very, very, very informative regarding autism, all the potential risks and all the potential contributing factors. It's impossible for me to discuss all of that here. So if you want to know more, give that podcast a watch. It has excellent content. So let me just summarize it quickly in case you're not convinced yet. To increase your antioxidant defenses, there are plenty of studies to confirm that the father with higher oxidative stress markers have a greater likelihood of having children with autism spectrum disorder. Oxidative stress to the sperm of the father can result in epigenetic changes to the sperm DNA, resulting in methylation and histone modifications, which ultimately affect fetal brain development. On the other side, oxidative stress in the mother before and during pregnancy can reduce mitochondrial function, which impacts egg viability and early embryonic development. And keep in mind, all of the mitochondria that the fetus contains are stemming from the mother, not the father. There's no mitochondria in the sperm delivering either the X or Y chromosomes. Oxidative stress during oocyte maturation can affect gene regulation in the embryo, contributing to autism risk. Maternal oxidative stress and inflammation before and during pregnancy can trigger maternal immune system responses, which also has autism risk. During early pregnancy, the fetal brain undergoes rapid development, making it highly susceptible to oxidative stress. During this time, high oxidative stress can lead to neuronal damage, impaired synapse formation, and inflammation. All of these factors are observed in autism spectrum disorder. The placenta is also sensitive to oxidative stress, leading to reduced nutrient and oxygen supply to the developing fetal brain and body. And even after giving birth, oxidative stress continues to influence autism risk. Breast milk contains antioxidants and essential fatty acids that help reduce oxidative stress, while some breast milk formulas lack these beneficial ingredients. And again, if the breastfeeding mother is undergoing a lot of oxidative stress and damage, then she's literally breastfeeding these reactive oxygen species to your child, which potentially has all kinds of deleterious effects, including autism risk. Once born, the baby is susceptible to environmental air pollution, pesticides, and dietary toxins, which can all induce oxidative stress in the infants and contribute to autism risk. And furthermore, oxidative stress may impair immune function, contribute to gut dysbiosis, and neuroinflammation in infants. Both are linked to autism spectrum disorder. And I'm not trying to fearmonger here. Obviously, it's going to be a lot easier for you to raise a healthy child compared to a child with autism or other kinds of complications because you didn't pay attention to your oxidative stress markers. So a little bit of caution is advised. Start preparing well in advance, both you and your partner, to keep the burden of oxidative stress as low as possible. Otherwise, you might face the consequences for a very long time. And in this case, we could take yours truly as an example. Both my parents were smokers and drinkers. My father drank and smoked while his semen was maturing. And then when he got his wife, my mother, pregnant, she was smoking and drinking throughout the entirety of pregnancy. And when I was born, I was sick as a dog. I had asthma, I had all kinds of allergies, I had all kinds of digestive issues, rashes, and it lasted for years until they figured it out to feed me a little bit better. But as soon as I started eating like a bodybuilder and removed all of the carbohydrates from my diet, so we're talking about 17 years old, then the asthma was gone and the rashes were gone and all of these digestive issues were significantly less. So I had to suffer quite a bit in my younger years because I suspect because my parents didn't do their due diligence researching regarding what they should have been doing before, during, and after pregnancy. So, right, with the information we have available nowadays, we don't have to make the same mistakes as our parents did. But if you do make the same mistakes your parents did, then honestly, dude, you're not fit to be a parent, and just get some dogs or a couple cats or whatever animal you prefer. All right, enough about that. Childhood traumas aside, at least I don't have autism, or I think that I don't. I'll leave it up to you guys if I have autism or not. I didn't end up being a girl due to the high oxidative stress that my parents were undergoing around the time of conception. Otherwise, this YouTube channel would have been called Vigorous Stephanie, and it would be about something entirely different. At one point, you're happy with your fertility parameters and you're ready to start inseminating. Not so fast, buddy. Just because you're not shooting blanks and you're staying on target doesn't mean that you're going to hit the target. The cervix is closed for 23 to 26 days out of the menstrual cycle, so you're knocking vigorously, obviously, and blasting against the door that only opens for 2 out of 4 days out of the month. Timing is everything. You and your partner need to start tracking her ovulation well before you're ready to start conceiving, assuming she has a regular menstrual cycle. Typically, ovulation occurs around 14 days before the next period, and it's highly advised to have at least 3 to 6 months of ovulation cycles tracked so you can time exactly when the cervix is fully opened and you can deliver your X and Y chromosomes. Basically, when you start improving your fertility parameters, that's the exact same time that your partner starts tracking her ovulation cycle. When you are ready to give, she knows when she's ready to receive. There are several apps that can track the menstruation cycle. We use Cycle Tracker by Apple, which is included in the iPhone. So ideally, you track her menstrual cycle for about 3 to 6 months, so you know exactly when ovulation occurs. And then the ideal intercourse timing would be 1 to 2 days prior and 1 to 2 days after the expected ovulation. You can go by basal body temperature tracking. When the basal body temperature rises to about 0.3 to 0.5 degrees Celsius or 0.5 to 1 degree Fahrenheit, which indicates ovulation. And then the ideal intercourse timing would again be 1 day to 2 days prior and 1 to 2 days after basal body temperature increases, indicating that ovulation is occurring. Or you can go with urinary luteinizing hormone testing, where you test her urine in the morning and evening with an LH ovulation predictor kit, abbreviated to OPKs, 4 to 5 days before expected ovulation. A positive test indicates that ovulation will occur in 12 to 36 hours. So the ideal intercourse timing would be within 12 to 24 hours after receiving a positive LH OPK test result. And there's even cervical mucus tracking, but you should leave that up to her because she's probably a lot more familiar with her mucus and how that's changing during the menstrual cycle than you are. When the mucus turns clear, stretchy, and egg white, that usually appears 2 to 3 days before ovulation. So the ideal intercourse timing would be 1 to 4 days after cervical mucus is changing. Regarding the intercourse timing frequency, to put it simply, more often is better. You can already start about 5 days before the expected ovulation, having intercourse every other day with everyday intercourse around the expected ovulation up to 2 days after the expected ovulation. So that means 7 days of highly enjoyable, vigorous manual labor of a few minutes to, let's say, half an hour every single time. And unfortunately for all the sex fiends out there, there's absolutely no reason to have intercourse more than once per day to prevent semen and sperm depletion. Keep in mind that while semen can survive in the cervix for up to 5 days, the vagina is a somewhat hostile environment for semen. No matter how much effort you put into your fertility protocol, semen isn't stored in the uterus. So if the cervix isn't open around the time of ovulation, that semen ends up dying. Yeah, so let me teach you how semen survives in the vagina and uterus. The vaginal pH barrier, the natural vaginal acidity, has a pH of 3.5 to 4.5, which prevents infection but is hostile to sperm. And again, when the mucus changes to the clear, stretchy egg white, like cervical mucus, the pH of the vagina also changes and comes closer to semen alkalinity with a pH of 7.2 to 8, which also neutralizes vaginal acidity temporarily. The semen coagulum, which protects sperm from vaginal acidity, usually forms within 1 minute of ejaculation. Semen liquefaction occurs a little bit later on, where prostate-specific antigen liquefies semen within 15 to 30 minutes, 60 minutes at maximum, allowing sperm to swim freely towards the cervix while vaginal acidity is neutralized. Again, as the cervical mucus changes around the time of ovulation, it acts as a sperm highway 2 to 3 days before ovulation, cervical mucus protects sperm from vaginal acidity, allowing it to enter the cervix within minutes of ejaculation, and the cervical mucus protects the sperm for a few hours. Now, the highly progressive motile sperm, the one that we're after in our fertility parameters, can end up and enter the cervical crypts, which are tiny folds within the cervix, where they can be stored for up to 5 days. And this guarantees sperm survival. This stored sperm survives until ovulation occurs, increasing chances of conception. So even though the cervix is open, but ovulation hasn't occurred yet, you can donate or deliver your sperm with high progressive motility into these cervical crypts, allowing them to be released around the time of ovulation. And then if you have additional intercourse around time of ovulation, imagine how much progressively motile sperm with normal morphology is present, increasing the likelihood of conception. But only around 1% from each ejaculation make it past the cervix. Sperm with normal progressive motility rely on flagella movement, aka tail whipping, and uterine contractions, more on that later, to move towards the fallopian tubes. This journey can take as little as 30 minutes to a few hours. So again, timing is everything, but with a few hour timing window, you should be okay in case, shit hits the fan and you need to do the deed a little bit later on, even though ovulation has already occurred. So don't stress. Don't stress. You'll be all right. Unfortunately, sperm only survives in the vagina for a couple minutes if the cervix isn't opened, meaning that your entire army of precious swimmers die 23 to 26 days out of the entire menstrual cycle, but they can survive for up to 5 days if you time it right and the cervix is opened and the cervical mucus helps your sperm along for the journey. So here's the ideal intercourse timing around ovulation. 5 days before ovulation, even though the cervix is likely closed, you can have intercourse. Then you skip 1 day, 4 days before ovulation, where the cervix is also likely closed. 3 days before ovulation, where the cervix is possibly opened, you can have intercourse again. Then 2 days before ovulation, where the cervix is certainly open, you don't have intercourse. 1 day before ovulation, where the cervix is open, you have intercourse again. Then on the day of the ovulation, you have intercourse. And even the day after ovulation, where the cervix is still open, you also have intercourse. Now, if you want to do it a little bit differently, you can have intercourse 4 days before ovulation, 2 days before ovulation, 1 day before ovulation, the day of ovulation, and the day after ovulation. I'll leave it entirely up to you. I've done it both ways, and unfortunately, after 15 months of trying naturally, which was highly enjoyable nonetheless, we decided to go IVF. After intercourse, have your partner lay on her back for about 15 to 30 minutes for normal semen coagulation and semen liquefaction to occur, reducing the acidity of the vagina. And with the help of the cervical mucus, the sperm is now allowed to swim into the uterus through the cervix, where it could potentially be stored for up to 5 days. And otherwise, if you time this around ovulation, then conception can actually occur pretty much immediately. There is some scientific evidence that female orgasm increases semen retention in the vagina by approximately 15.7% compared to not having an orgasm. How much that actually contributes to an increased chance of fertilization, I'm not entirely sure. It was a small study with only 6 participants, and they used a semen simulant and not actual semen because they probably wanted to prevent pregnancy in these 6 participants to measure the backflow of the semen following the use of a vibrator. Again, the citations are down below. I got this paper from Dr. Dean St. Mart ages ago. I think his wife found it online somewhere, so she tried to convince him to give her an orgasm around the time of conception, and I used it as scientific evidence to give my wife an orgasm around the time of conception. But when you look at it closely, keep in mind that if you do try to increase fertilization chances by giving your partner an orgasm, her orgasm needs to occur after you've already ejaculated and the sperm has coagulated and liquefied for the semen to travel into the cervix and uterus. So if you're like me, where your partner has an orgasm first and then you ejaculate, then her orgasm comes too late. She needs to have an orgasm after you ejaculate, and already the semen already went through the process of coagulation and liquefaction for the sperm to be liberated. So the timing is a little bit off here. Still, an orgasm for you and her, perhaps not in that order, is still highly enjoyable, for emotional bonding and that kind of stuff. But if you go with this scientific evidence, you need to ejaculate first and then keep her going while she's laying on her back for approximately 15 to 30 minutes. Or you can bail out and set it to vibrate and tell her to finish herself off, Ali G style. The correlation between female orgasm and pregnancy rates has been widely contested in scientific evidence. You can read all about it following the citations down below, but take it from me, if you're a loving and caring husband, ensure that your partner, your wife, has an orgasm or two every time you're trying to conceive, and even during the off period where she's not receptive to semen and you're still attempting to have a good time. Make sure that she has an orgasm or two, because when she's pregnant, when she's highly pregnant, right, towards the end of carrying your child, then intercourse might be a little bit difficult, but there's always alternative ways for you to get stimulated. Yeah, and that's where the gratitude starts to show for all of those orgasms that she had. All right, and I think that pretty much covers everything I wanted to discuss in this video. Keep trying until she's pregnant. It might take months to years, probably longer than you initially expected. And if it doesn't happen within a window of time that you feel comfortable with, both you and her, then you have the following alternative options. There's testicular sperm aspiration, where they inject a needle into the testicles and use aspiration to retrieve semen. I would consider this a last resort. I think the fertility medications are going to get the job done. If you followed this video all the way through, I don't think you need testicular sperm aspiration unless you did something terrible with your testicles or, well, cut the vas deferens leading to infertility. There's female fertility medications treatment that has nothing to do with you, but maybe that's something your wife or partner needs to consider. There's clomiphene citrate, which stimulates egg maturation and induce ovulation. Various gonadotropin, including human chorionic gonadotropin, follicle-stimulating hormone, and luteinizing hormone injections, or various combination thereof, which stimulates egg maturation and also induces ovulation. There's letrozole, which induces ovulation, again, by crushing serum estradiol levels. Luteinizing hormone, follicle-stimulating hormone levels go up. Works the same for her as it would for you in the context of not using exogenous testosterone replacement therapy. Glucophage, aka metformin, can improve ovulation in cases of polycystic ovarian syndrome. Again, a hysteroscopy will determine if your partner has PCOS. Then there's intrauterine insemination, where your sperm is washed and directly inserted into the uterus around 24 hours of ovulation, which is often combined with human chorionic gonadotropin treatment to induce ovulation in her. Then there's in vitro fertilization, where the eggs are retrieved from the ovaries and fertilized with sperm in a fertility laboratory. So if you're undergoing a good amount of gonadotropin treatment to stimulate egg maturation, that usually goes in combination with IVF, right? You have gonadotropins to stimulate egg maturation, so you get 12, 18 eggs or maybe even more that are mature, ready for retrieval. Then with in vitro fertilization, they use needle aspiration to collect the eggs. So if you have 12 eggs, that's 12 insertions, aspirations of a needle. And if you have 18 eggs or more, that's again 18 aspirations or more. Whatever eggs are retrieved are fertilized in the laboratory, and then they can do special treatments for that. IVF intracytoplasmic sperm injection, where a single sperm is injected directly into the egg. This is better known as ICSI. And then there's IVF intracytoplasmic morphologically selected sperm injection, better known as IMSI, where the sperm is examined under a high-powered microscope to identify abnormalities in the head, midpiece, and tail. And then only a single morphologically healthy sperm is injected directly into an egg. IVF is cheaper than ICSI, and ICSI is cheaper than IMSI. Then you have donor sperm or donor eggs, where donated sperm or eggs are used for intrauterine insemination or in vitro fertilization, whether that's ICSI or IMSI. And as your last option, there's surrogacy or gestational carriers. With traditional surrogacy, the surrogate's egg is fertilized using a donor or partner sperm by direct insemination or intrauterine insemination. And gestational surrogacy involves an in vitro fertilized created embryo, which is then carried by a surrogate. And whether they use a donor egg and donor sperm, or the egg and the sperm from the parents, in which case the embryo is being carried by a surrogate, I'll leave that up to you, which route you need to go with. Discuss that with a fertility specialist, obviously. And then last but not least, there's always adoption, right? You take somebody else's child and raise it as your own. So there's plenty of options if you do want to have a child in case this fertility protocol is unsuccessful because of steroid abuse and high oxidative stress and whatnot that you did to your testicles. So there's always hope and always options. But I think the large majority of you guys can get the job done if you watch this video from start to finish, and make sure you leave a like and a comment and subscribe if you haven't already. And if you have a son, I heard that Steve is a pretty cool name. All right, I'll leave it here. Thank you guys so much for watching. You can find everything that I'm associated with down below in the YouTube description section, the citations, the links to the graphics, additional material, podcasts, and videos. It's all there. Do additional research so you know exactly what you're getting yourself into when you're trying to get your partner pregnant after years and decades of steroid use and abuse. And while you're at it, use some of my discount codes and affiliates to get yourself a discount while shopping online. And if you go do your blood work, do it over at Merrick Health, which have extensive lists of blood work parameters so you can keep yourself healthy. They even have tests for oxidative stress markers, which not many clinics in the world have on offer. Vigorous crew, you guys know what to do. A anabolic high fertility frontable bicycle for you guys. Good luck inseminating. And, well, if you have some good news for me to share, just tag me in your baby pictures. I'll be happy to see them over the next couple of years. See you guys in the next deep dive.